Rangers out back last night.
Or last night?
Last night. We do an optional Wednesday.
Oh, that's right. We had a right one. He was debating coming.
Good guy.
Jason.
Oh, you big tall dude?
Tall dude.
I like Jason.
He was good.
Yeah.
I guess he lives by Einer or something.
What's that?
I guess he lives by Einer or something, so his buddies are there. He was a good dude.
And you know we have a Ryan Hunter in here.
That's what I heard.
Right?
And no relation, right?
None.
No, except Ryan Hunter followed him.
Right.
Once you become a bike app.
Yeah, Molly observed it on Tuesday, and that she had it in her email, and then I saw the same thing last night with him, and there was crying out back.
Copy. Well, at least he came last night.
Hmm?
Something like this.
Mm-hmm.
Worked on it.
Yep.
Thank you. Thanks, sir.
Thank you.
Aye.
Just some reference material. Captain Burge is on his way. I don't know if he wants to talk to you for a minute before we get started or not. So we're just gonna hang tight for a minute.
Okay.
Okay.
I did my IV day at the hospital yesterday.
How was it?
How'd that go?
That was a bloodbath, sir.
Nice. Do a little bloodletting, did you?
Yeah.
Okay.
It's a bloodbath.
Yeah.
That's awesome.
It's like every patient they had Coban all over the place. It was great.
Yeah?
Good job, Murphy.
Yeah. I think I ended 50-50 for the day.
Well, 50% is better than 49%,
I agree.
right?
No arguments there.
So,
Right.
Almost got the detail on the shoot.
Did you really?
morning, sir.
Morning, how are you?
The,
Good, how are
Doesn't
you?
normally set it bus.
the dude that had the Pope
Does he have anything in his arms?
Oh, there's one over there. That was awesome.
It was on greener side of the bus. It was up there. So. I don't know.
Did he do DJ?
Oh, yeah. He got it.
See Swiss cheese pretty good.
I think at least 4 shots.
Okay.
But he was alive. Man.
Is she conscious still?
No, he's like,
Is it one of those where you're doing CPR and it's pushing out every hole as fast as you're pumping it?
you know what? It wasn't. But he had already bled a lot.
We had those two kids outside helping apartments in Midvale. We had John and Rob and Cora. Kids
How are you?
Pole, so we had to take them to
Living the dream.
Are you now?
No.
Heck, yeah.
It's just,
Didn't you go somewhere?
Yes,
Just like, all right,
Hawaii.
I'll start patching the bucket.
Kid,
I know.
a hood rat kid, or he was like a bystander?
No, they were, that was the
Yeah.
two teenagers that were like
It was great.
16 and 14 or something.
She
related.
Well, we didn't do helicopter.
So the sister there and my dad was just the bowls.
Oh, well, that's the problem. It's just that. Right on. As soon as they leave, then you get busy.
Yeah, she did, yeah. He
Yep.
walked out the door and then they had a call for a fire, so. Hey Rob, I'd like to ride along. Jason? Really
Jason?
good guy.
Big tall guy.
Really good guy.
6'8".
6'5" or something. Is
Yeah.
that what it is?
I don't, he looks 6'8" to me,
Yeah,
Cora, but.
Well, to me
Well,
too.
I look 6'8".
He's I really like Jason as well.
He's a good guy.
Yep, I agree.
He just dove right in, asking all kinds of questions.
Good.
Really,
He's doing well in class, and I just like the guy.
yeah, definitely. I mean, good person. I don't know, Kelly's on too.
Yep.
So,
Cool.
yeah.
You ready?
Anytime.
Okay.
I didn't know if you wanted to talk to him first.
No. Any questions, concerns? Are we doing all right? Okay.
lot of
So-
blankets flooding.
No, it's 8 o'clock and it's getting dark and that's, you know, we still have almost a full moon, so. Alright, so, kind of the way it's gonna go, today we're gonna go over, some pretty, the airway concept and then disability, so the neurological and C-spine and head injuries. And then, I believe, is it next week? They're gonna go over just like a wrap it up and we'll do some quick scenarios and then a review and then we'll have the final test on, I believe Tuesday? This Tuesday?
Tuesday of this next week?
Uh-huh,
Yes.
yeah.
Oh.
But then we're gonna delve into just nothing but trauma for another week, and mostly out of the book. And then that's about it for there, and then we go into, pediatrics.
Week from today is gonna be all skills.
I'll be in Montana, sir, I'm sorry.
It's okay, but all of you.
Excuse me?
It's my birthday.
Yeah, it's his birthday. He's gonna be fishing. He's trying to get a new
Well, I'm not even gonna be here, so I don't care.
Okay.
We're not gonna be here.
Yeah,
Oh, wait a minute, Thursday I'll.
you'll be here Thursday.
I'll be here
Tuesday,
Thursday.
I'm sorry, this next Tuesday, here in just a couple of days, is
Right.
the Piddles final.
Yeah.
Right.
And that's available, going to be available on LMS
Mhm.
for those who are on B platoon and or working trades.
Yes.
Okay.
Alrighty?
Yes, sir.
Okay, cool. I'm gonna turn the time over to John.
Fiddles,
Get
not
started.
fiddles.
Piddles? Fiddles?
Fiddles.
Fit.
TH is
Fit.
like, yeah, like fun.
The pride.
I had my physical yesterday.
Or
and the doc's like,
fast.
Your urine has tons.
I like fiddles, John,
Okay.
but
we can do
I'll say fiddles.
We can do fiddles. I'm easy. Oh. Well, I don't know if you're gonna be able to do this or not.
Came online.
Oh, you're not.
Adequate?
Cool. That was your shift.
Great.
Perfect. Great shift. Adequate.
Is that on there? Okay, let's get started so we can get out of here.
Yes.
So, we are going over airway breathing, oxygenation, all the stuff that, hope this works, yeah, that we have gone over about 3 times already. So this is really 100% review here. But it's a requirement for Piddles. Don't mess with that.
I didn't know if it was working. That's,
Set up. It's working. Well, I hope it's working. It says it's on. Yeah. You can turn that around and watch from there if you want.
I'll just be quiet.
Are we gonna use our inside voices?
No, just me.
Just you. Okay. So first of all, we'll just do a little bit of review. When we're talking about breathing and ventilation, we got to talk about the thoracic cavity. And probably one of the biggest components of the thoracic cavity are the ribs. There's 12 pair of ribs. 10 of them are attached at both the back and the front. 2 of them are floating ribs that are only attached at the back. Each one of these ribs has a nerve, artery, and vein, and they're on the inferior border of each rib. What's the inferior border? The bottom of the rib. Why is that important to us?
When you start sticking needles in there, you don't wanna catch one.
Right. You want to be aware of where those nerves, arteries, and veins are when you start poking into that thoracic cavity. So this comes into play when you're doing a thoracic needle decompression. You want to go over the top of the rib. You don't want to go on the bottom of the rib. Because especially if you lacerate that artery, you can cause some hemorrhage. They're small, but you can still cause hemorrhage, which would cause what in the thoracic cavity? Hemothorax, right. Okay? All right. So we've got I passed out some little diagrams here of some of this stuff. Basic anatomy, you have the trachea, which is also called the windpipe. Directly behind the trachea is the esophagus. What's the esophagus? Food pipe. So the superior and inferior vena cavas. Where does the superior vena cava come from? What blood flows into the superior vena cava?
The returning blood from the head and the upper body.
Head and the upper extremities. Okay? Inferior vena cava comes up through the diaphragm, comes up inferiorly. What comes up with it? Blood from where?
Lower extremities.
Lower extremities, pelvis, abdomen. Okay. All right. What's the major vessel that supplies oxygenated blood to the body? Right there. Comes right up out of the top of the heart. What's it called? Aorta. Very good. So it supplies oxygenated blood basically to the rest of the body. And what else does it supply oxygenated blood to? It's very important.
Heart and brain.
Heart. Yeah, especially the heart. So right off of the aorta as it comes up out of the heart are the branches for the coronary arteries. Those are really important. Okay. Only other thing really that you need to remember is the trachea divides at what we call the carina, which is right about here, divides into the right and left main stem bronchuses. Little bit of trivia on them is the right main stem bronchi is pretty straight. Left main stem bronchus comes off at an angle, but the right one comes down pretty straight. So where do you think things are going to go if they come down the trachea? Foreign bodies and stuff. Going to go into that right main stem bronchus. That's where you get a lot of obstructions in the bronchuses. Okay. The other important thing to remember about the thoracic cavity is that it's fairly well protected by the sternum and the ribs. Okay? Mediastinum basically is composed of the heart and the aorta. We kind of talked about the aorta already. The aorta comes up, branches off, and major vessels head up to the brain, the upper extremities, and it curves down and heads down into the abdomen and pelvis, and then bifurcates in the pelvis into the arteries that go, the femoral arteries that go down into the lower extremities. superior and inferior vena cava we talked about. Pulmonary veins, we really didn't talk about them much. The pulmonary veins, where do they come from?
The lungs.
From the lungs. Okay. Any questions about the thoracic cavity, mediastinum, the heart, any of those structures in there? All right. So physiology of oxygenation and breathing. Remember we talked about how the capillaries wrap around the alveoli in the lungs? How big are those capillaries?
Yeah, for one cell.
Yeah, they're only big enough for one cell to pass through at a time. So those red blood cells pass through in single file around those alveoli. That's where the gas exchange occurs. Basically, it allows the oxygen to attach to the hemoglobin in the red blood cells. Also delivers the waste products from the red blood cells into the alveoli to basically be excreted by respiration. Okay. Breathing. How important is breathing? Pretty important, right? What does breathing supply us with? Oxygen. What else does it do? Gets rid of the carbon dioxide and the bad stuff. Okay, pretty simple. It's controlled in the respiratory center of the brain, basically in the medullary area. There's also chemoreceptors in the aorta and the carotid arteries, and they can stimulate the respiratory system too. That's one of the reasons if you have somebody that is tachypnic or hyperventilating, or if you have somebody that's in PSVT and you're going to do vagal stimulation on them, you have to be real careful if you're doing carotid massage at all, because you can't affect the respiratory center through the baroreceptors in there. Okay, any questions about basic breathing? Is normal breathing really super noticeable?
No.
I mean, if you walk into a room and look at somebody, is it really easy to detect if they're breathing or not? Well, if they're awake and talking to you, yeah, that's probably a pretty good sign. The biggest problem is most of the time you really can't hear somebody breathing unless you get really close to them, unless there's a problem. So if you walk into a room, and we've kind of talked about this all before, but if you walk in and your general impression of somebody, if they're breathing noisily, what does that mean?
Some type of obstruction, upper or lower airway.
Yeah, there's probably some kind of problem, right? Especially if they're not able to talk in complete sentences. They're really in trouble if they're not able to talk at all. But if they're not talking in complete sentences, they're just talking one word at a time, or they're gasping, or you walk in, you look at them and they're tripoding. What is tripoding indicative of?
Four hours of breathing.
Yeah, they're working really hard to breathe. There's a lot of reasons for it, but they're working really hard to breathe. So when you're assessing somebody breathing, the most important things that you can do is look, listen, and feel. What are you looking for?
Chest rise?
Okay, chest rise.
The difficulty remembering talking.
Yep, yep. look and see if there's anything really noticeable. Nasal flaring, breathing with their mouth open or gasping. Listening. How do you auscultate for lung sounds? Where do you listen?
At least 4 spots.
Listen in the front, upper right, upper left, lower right, lower left. What about posteriorly?
You can if you feel it's necessary.
Yep. Actually, sometimes it's easier to hear them posteriorly.
I think more often than not, John, in the field, you see here, 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 and here.
Yep.
I would say 98% of the time.
And why is that?
It's what we're accustomed to doing.
And it's easy?
It's easier for with our patient's position.
It's close, right?
Right.
Yep. So when you're listening to breath sounds, what's an important position for them to be in? Sitting up. Yeah, you can hear breath sounds a lot easier if people are sitting up. And it's a lot easier to access those areas. What are some of the things that you're listening for? Wheezing, crackles, stridor.
Actually have air movement.
Yeah, yep. Here, just listen for air movement. When you're talking about, especially with kids, like this kid, what do you notice about this kid?
Chest sunk in.
Okay, first of all, you've got retractions here. That mouth is wide open.
Sniffing position.
Yeah, and he's kind of in a sniffing position. This kid's having a hard time breathing. Now, we don't know why, but he's having a hard time breathing. So what are some of the things you might think about with this kid? Croup, kid this age, RSV, especially if they've got a recent history of illness, especially if they've had fever. So with kids especially, watch for the nasal flaring and the retractions. They'll have retractions right here along the costal margin. They'll have retractions along the sides of the ribs in here. They can have retractions up here in their clavicles and around this suprasternal notch up here. And they're usually pretty prominent when kids are having trouble. So when we're talking about trauma, what are some of the signs of trauma as far as the chest is concerned that might affect breathing?
Some of the signs,
Yeah.
penetrating wound to the chest, that's probably going to be your
Wounds?
most obvious.
Bruising.
Bruising from blunt force traumas.
Yep.
Swelling.
You might have a little bit of swelling, but usually the chest doesn't swell a lot. The problem with the chest is it won't expand and contract regularly. The mechanism of injury, right. What happened to
indicator.
them? Is that steering wheel completely wrapped around the steering wheel post? Have they impacted a large object? If they're on a bicycle or motorcycle, have they impacted something with their chest? So look for any kinds of signs of trauma. There's a whole bunch of them. Bruising, obvious fractured ribs, severe respiratory distress. What about a sucking chest wound? What does that sound like? You can hear the air rushing in and out, especially right around the area of the injury. What's a typical cause of a sucking chest wound?
Penetrating traumas.
Penetrating trauma. Gunshot wound, stabbing, or anything else that can penetrate that thoracic cavity. So when you're listening, Listen to see if the breath sounds are equal on the right and left. Listen for any abnormal sounds and make sure that they're asymmetric. You don't have absence on one side or the other, or it's not, you don't have unequal breath sounds on one side or the other. Abnormal sounds, we've already kind of talked about wheezing, rowels, rhonchi. Rowels and rhonchi are just noisy breathing. It's really not too critical that you identify the difference between the two. They're just noisy. Crepitus. What's crepitus?
It's the sound and feel of broken bones. How's that?
Two bones rubbing together. Bless you.
Thank you.
You be okay?
Yes.
Okay. So, has everybody felt crepitus? Like a fractured extremity, especially, where they've got a fractured extremity and you hold on to it to splint it or something, and it moves a little bit, and you feel that kind of grating, kind of raises the hair on the back of your neck. Yeah. You can get that in the ribs too. Bless you. It's contagious. Okay. So when you're palpating the chest, you want to palpate all of the ribs, both anteriorly and posteriorly, and especially along the side. What I like to do is I like to put my hands laterally right on the sides of the ribs and have them take a deep breath. And you can feel that expansion. You can feel if it's kind of equal. You can feel crepitus. Bless you.
There was.
Let's come back.
Okay, Rob, you're next.
I'm up.
Yeah.
Okay.
Subcutaneous emphysema. Does everybody know what that is?
Rice Krispies.
Rice Krispies, exactly.
Yes, please.
That's air in the subcutaneous tissue. What's it usually caused from? Either a pneumothorax or some kind of penetrating injury that's allowing air to escape into the subcutaneous tissue. The most common places are the upper chest area. You can even get it up in the neck. The armpits are a really classic place to feel subcutaneous emphysema. And it does feel like Rice Krispies. You'll feel it and it kind of goes snap, crackle, pop.
Rice Krispies.
Yep. The other thing that you're looking for is any abnormal movement of the chest wall. And we're going to talk about it in a couple of minutes. And any tenderness when you're palpating the chest. Pneumothorax. So it can be a simple pneumothorax, tension pneumothorax, or an open pneumothorax. What's a simple pneumothorax?
Not yet putting pressure onto the other side.
Yeah, it's just air in the thoracic cavity for whatever reason. Lots of different reasons. The most common cause of pneumothorax is rib fractures. A tension pneumothorax is when you get a lot of air in that thoracic cavity and it starts pushing on those structures in there. It starts pushing on the lung, actually pushes on the heart, and it can push them over to the opposite side of the injury. Open pneumothorax is basically a sucking chest wound. Hemothorax. What's a hemothorax?
Blood in the thoracic cavity.
Blood in the thoracic cavity, right?
Murder.
Yep. And it can be caused from a lot of different things. Flail chest. Does everybody know what a flail chest is? What's the definition of a flail chest?
2 or more broken ribs that are floating. No.
Basically, 2 or more ribs fractured in 2 or more places.
Okay.
So basically what it's done is it's created a segment
Yeah.
of ribs that aren't attached to anything
So
else.
floating.
Yeah, they're basically floating. And there's another slide on it.
Just wanted to make sure
We'll talk
I
about it.
justified myself.
So we've kind of already talked about pneumothorax and how it can progress into a tension when the air continues to accumulate in the hemithorax on the side. So how do we fix it? Especially a tension.
Decompression.
Needle decompression. Okay, how do you do that?
We don't.
Okay, but you may be helping with it.
Yeah, we may.
In fact, you probably will be helping with it.
Cool.
If you're gonna do it.
Second, third.
So you insert a needle. Most common place is the second intercostal space. Does everybody remember how to find that second intercostal space?
Mm-hmm.
Okay. Feel your sternum, and if you go down the sternum a little bit, you'll feel a bump there. Kind of towards the top of the sternum, there's a bump. That's called the manubrium.
Mm.
Where that bump is where that second rib comes off. So that's where the second intercostal space is. Remember I taught you that when we talked about 12 lead placement? Find that bump on the sternum and you'll find the second rib. It's easier than trying to count down because that first rib is hidden underneath the clavicle. Okay. Some of the signs and symptoms of pneumothorax: decreased breath sounds, mild to moderate ventilatory distress. Usually they'll be in moderate distress with a pneumothorax. It can progress to severe respiratory distress, especially if it becomes a tension. We already kind of talked about tension pneumothorax. Biggest problem with tension pneumothorax is the hemodynamic compromise because it's putting pressure on that heart, so the heart's not able to pump as effectively. It's putting pressure on that unaffected lung, and obviously it's putting pressure on the affected lung. So their respiratory capacity can be reduced by 50 to 75%. Open pneumo, sucking chest wound, talked about that. You can hear it or you can see it. If they've got a penetrating injury and there's blood there, you'll see it bubbling if there's air coming out of it. So there's been a lot of controversy about how to take care of these sucking chest wounds. You can apply a semi-occlusive dressing. I wouldn't apply a completely occlusive dressing on it, but you can apply a semi-occlusive dressing on it, which means you put a dressing on and it's sealed on 3 sides. There's commercial devices out that we even carry them that you can put on a second chest wound. Basically has kind of a one-way valve type thing. But they say a lot of these things don't really work as well as they're cracked up to be, and a lot of them are kind of expensive. So,
John, have you used our product, the Halo Chest Seal? Has anyone in here used the Halo Chest Seal?
I've used it not on a sucking.
Okay. Okay.
According to their video, you can pull it up
You
to burp it.
you burp it every 2
and
minutes.
it'll reseal as many times.
I've never
Right.
burped it.
You have put it on though?
I haven't put it on yet.
yeah. And that's the
Just
biggest
curious
danger
to have
of
it.
putting an occlusive dressing on, is that you can actually, if they don't have a tension,
Scratch,
which
scratch,
a lot of times they won't have a
My
tension
belly.
pneumothorax if they've got a second chest wound, because that air is coming out. But if you occlude that hole where the air is coming out, and if there's air going into that cavity, what's going to happen? It's gonna fill that cavity up with air, cause tension. So you have to be careful. Hemothorax, it's just bleeding into that pleural cavity. What can we do about it?
Diesel.
Transport. Recognize it, and rapid transport. We can't do anything in the field for a hemothorax. So if you're suspicious of it, you're gonna have to get to the hospital, they need a chest tube. Simple rib fractures are the most common thoracic injury. They can cause a lot of problems, mostly pain and respiratory distress because it hurts to breathe. So they'll have ineffective ventilation because it hurts to breathe.
Hey, John.
Yeah,
AirMed and my flight, can those guys do chest tubes?
yeah, yes. Yeah. But a lot of the area around here, you can have them to the hospital before a helicopter can even land usually. Yeah, talking about that real quick. So the helicopters, they're great. They have a lot of use and for a lot of things. But one thing you got to remember is when you start thinking about needing a helicopter or call for a helicopter, realistically, it's probably going to be 15 minutes at least before a helicopter gets there. Because you got to remember, okay, you want a helicopter, so what do?
Ask for more.
Dispatch.
You call dispatch, okay? And sometimes they'll ask for information. So you're already a couple minutes there. Then dispatch has to figure out which helicopter they're going to call. That's another couple of minutes. They call the appropriate agency. Their dispatchers get information about where it is, ground contact, and basically what the problem is. Another couple of minutes. Where are we now? We're already at 6 minutes, if you're lucky. Then they have to dispatch their crews. Are the crews sitting in the helicopter waiting to start it and go?
No, they're napping.
All right. Yeah, they're doing busy work in the hospital and stuff. So it's going to take them probably a minimum of 5 minutes to get to the helicopter. Bare minimum to even get to that helicopter. Then they got to unplug it. They got to get things ready. They've got to do a safety walk around, and they got to start the thing. How long does it take to start a helicopter?
3.5 minutes.
Yeah, a couple of minutes, depending on which helicopter they are. But most helicopters take at least 2 to 3 minutes to start. Already, we're way over 10 minutes, 12 minutes. Then, they've got to get it started. The pilot's got to do his checks, make sure everything's going right, make sure he doesn't have any buzzers or whistles or bells going off, and then they got to lift off. And how long does it take them to get to where you are?
Yep.
Depends on where you are. It may take them 10 minutes to get to where you are. So how far out are you now?
25 minutes.
Yeah, you're 20 minutes at least usually. So the thing about the helicopters, if you even think you're going to need them, call them and tell them. Get them on the way. If you don't need it, you can cancel them. No big deal. They really don't care. It frustrates the crews when they get to a scene and people are yelling at them, "Where have you been? You know, we called you 20 minutes ago." Well, you know, it's hard when people get upset with you, but that's the reality. And I know sometimes crews will say, "Yeah, it only takes us 5 minutes." Bullshit. I call bullshit. It may take them 5 minutes to get to the scene once they're airborne. yeah, but there's nobody out there that can get to a scene in 5 minutes. Nobody. I don't care who they are. So, helicopters, if you're thinking about it, call them. Get them en route. They'll be more than happy to turn around and go home. Or they'll be even happy to come to the scene, land, and say, you really don't need us. We'll go home. You can transport them. Okay? All right, enough about the helicopters.
John, you'd probably know, aside from specialty like pediatric, how does dispatch decide between airman and life flight? Is it on a rotation, or how does that?
It's a rotation. Yeah. Yep. Okay, flail chest. We kind of talked about it. 2 or more ribs fractured in 2 or more places. It causes what they call paradoxical movement. So when the chest expands, that section that is flail, that is broken, it doesn't expand, it goes into the thoracic cavity. When the chest doesn't expand, that flail segment will expand out. It's really weird to watch it. Has anybody ever seen a flail chest? Anybody in here? It's pretty dramatic. If you see it, you'll go, oh, holy shit, that's what he was talking about. Because that segment just moves in and out by itself. It's really weird. The biggest problem that it causes is it can cause a pneumo. There's not a whole lot you can do for it. You can kind of try and splint that flail segment. You can either tape it real quick, or you can put a pillow over it, just hold it. They used to use sandbags, put sandbags on a flail segment. That doesn't work real well. A lot of times they have underlying problems, the hemothorax pneumo, or they can cause a pulmonary contusion. What's a pulmonary contusion? Bruising of the lung.
Mm-hmm.
That's it. So basically you've just caused a big bruise on the lung. What does a bruise consist of? Blood. Okay, right. And so what'll it do? It'll compromise those structures in there. It'll compromise those alveoli. They won't work as well. So consequently, you don't get as good a respiration, internal respiration. So when we're talking about chest injuries, what's the biggest thing that we need to do? Make sure that they're oxygenated well and that they're ventilating well. That's probably the most important thing that you need to do. How are we going to make sure that they're oxygenating well? O2.
Mm-hmm.
Put them on O2. It's not going to hurt them. What else? What if they're not breathing adequately?
Breathe for them.
Breathe for them, right? System. Take care of any wounds. Take care of any bleeding that they have. And really important is to recognize if they have attention. If they have attention, that's a true medical emergency. You're going to have to do something about that. With chest injuries, you have to continually assess their respiratory status. Keep an eye on them all the time. Watch their breathing, see how well they're breathing. What's something that you can do to see if they're adequately breathing? What's a device that we carry? Pulse ox. Yeah. This is a good time for your pulse ox when you have chest injuries. See if they're adequately oxygenating. What kind of O2 sat do you want to have?
95s.
Yeah, 95. So probably remember 95. That might be on the test. 94 to 99 is what we're looking for, but at least greater than 95. continue to reassess these people. I can't stress that enough. Assess, assess, assess. Ventilations, if they're over 30 or less than 10, you're going to need to assist them because they're not adequately getting internal respiration. If they have poor chest rise or they're using accessory muscles, what does that mean? They're in trouble. So you're going to have to do something. If their SATs are dropping, what can you do?
Try and fix it.
Yeah, either change the device or make sure that their airway is adequate, good patent airway. See if you can find out what the problem is. If you're bagging them and you've got an end-tidal CO2 detector on there and their end-tidal CO2 starts dropping, or if it starts really increasing, figure out what's going on. Either you're breathing too fast for them, or they're breathing too fast, or not fast enough. And consider airway management. What's some of the typical things that we do for airway management?
Simple adjuncts to, more advanced adjuncts to,
Right.
to BVMs, to NRBs, to
Right?
all of it.
Yep. Oral airways, nasal airways, BVM, even vents. We don't carry vents, but just remember that in case it's on the test somewhere. So, how fast you going to breathe for adults? 10 to 12 minutes, every 5 or 6 seconds. This says a tidal volume of 500 to 800. That's a little high. Most adults are 400 to 500. Most important, just take a look at their chest. As soon as you see their chest start rising, that's adequate. Okay? You don't want to continue to give them more air if that chest is rising. You're not really giving them more air, you're just causing more insufflation. Kids, 16 to 20, 100 to 500. Actually, most kids are anywhere between 100 and 250. So remember what we talked about when we talked about ventilating in that bag? Most important thing is not to crush that bag, no matter which bag you're using. Don't crush it. Just push on that bag. Probably halfway is 20 most of the time. Use your capnometry and capnography. Capnometry is just your pulse ox, and the capnography is the end-tidal CO2 detector. If you have an end-tidal CO2 detector on there, you want to make sure, or you want to try and keep it between 35 and 45. If it gets down around 10, yeah, you're in trouble. If it gets up in the 60s, yeah, you're in trouble. So figure it out. 35 to 45 is optimum, but you don't have to really keep it that close. Tension pneumothorax, we already kind of talked about needle decompression. Where do we do it?
Second or intercostal mid-clavicular.
Okay, good. How do you find mid-clavicular? We already kind of talked about how to find the second intercostal space, but how do you find mid-clavicular? Open up your hand, put your thumb in that suprasternal notch, put your middle finger right over on that bump on top of the shoulder. That bump is the end of the clavicle. Okay? Once you do that, you look at it, you just find the middle.
I'm going cross-eyed trying to do that. Yeah. No, I saw it.
Do it on me. Where's the middle?
Right here.
Okay. Good job. You didn't go cross-eyed.
He's already broken those things several times.
Yeah.
Fun.
Yeah.
Easy glass man.
Okay,
Bubble boy is what I prefer.
if you do that, when you place that needle, what's the important thing about placing that needle?
Go on the superior side of the rib.
Yeah, you go up over the top of that rib, make sure it's the top of the rib. Stay away from the bottom of the rib that's above it in that intercostal space.
Just trying to show.
Okay. Any questions about needle decompression? All right. So, when you've got a trauma patient with chest injury, maintain their airway. If they don't have a patent airway, are they going to breathe? Yeah, they're either not going to breathe or they're not going to breathe well. So make sure that they have a patent airway. And give them oxygen. Don't withhold oxygen from people. Go ahead and give it to them. You can use some of your monitoring devices. Use a pulse ox. If you're breathing for somebody, ventilating somebody, use that end-tidal CO2. Yes, sir.
John, it's out of our scope, and as AEMTs, we're not going to do needle decompression, but if time allows, since you've stated that, you know, we can assist with, and we probably will be in that situation with our one-on-one paramedic partnership that we're about to embark on.
Right?
If time allows,
With a smile.
could we practice?
Yes.
Right.
Yes, we can do that next week.
Could we do it?
We have mannequins here that we can do needle decompressions on, and we can practice them. And I think that that's something that you guys should practice. Because like you say, you won't be doing it in the field, but chances are you will be assisting with it in the field. So it will be good for you to know how it's done,
Yeah.
the signs and symptoms, where you're going to place that needle, how it's done, and what to do for it afterward,
Thank you.
and complications. Okay? Okay. Any questions?
No, sir.
You guys are all chest trauma experts. Bitchin'.
When's the next cadaver lab? Captain Burge, John Maxwell.
Thought there was one coming up.
We usually have one around March,
Yeah.
April.
Could the AEMT students request the cadaver lab to practice LMAs on a real body and decompressions on a real body and stuff like that?
I don't have a problem with it.
Yeah,
And
I have a budget of 2 bodies per year.
IO drills on a real body? Huh?
I have a budget of 2 bodies per year.
Yeah. I know.
Since we didn't run a paramedics class, I didn't even think about it, but, yeah, let me talk to Chief Wade. And
Cool.
I'll see if I can.
IOs would be awesome on a real body, if we could make use of a body.
Do all the airway adjuncts. Cool.
Right?
Thank you for looking into it.
All right, yeah, no worries. So take a 10-minute break and then Alex is gonna spool up this nice one.
Okay.
Over off Fifth West and South. What is it? What is it?
Yeah.
Implement composers instant command system. How interesting. No one be able to know how to implement this.
Yeah.
Understand hazards and risks associated with employees working in chemical protective programs. Talking about like some kind of like work cycles. I would imagine, just like setting up children. That'd be nice. Just think it'd be good. Get some of that perspective.
What's that for Al?
Just those
Little bit of
days,
prep.
on those times when
Oh, he's got 2?
that last one, me and Sean made entry on. Yeah, we have one now.
I think he's making some copies copies up there, if you wanted to say.
I'll go see if I can help him out.
Yeah, see if he's a little bit, you know, in or out.
It's nines that have two, 126 that have one, and 124 that have none. But, let's go with this one. Let's go with this one, being partner. I could be getting paid more to do it. Chassis. How this all works out. Yep.
We still understand a little bit further talking about closing down the station site. Let's get more.
Well, it's not really, basically, the point was, we're talking about pulling it out, is fight for what we already have. Keep what we've got. With that comes more.
That's true. Don't go on one.
But they say each has no problem hiring or promoting. But I just like, last entry, me and Sean and one I came, you had Charlie on 124 doing it, and you had Sellers and anyways, it's basically tied with the, it's the hazmat crew suit.
Really?
Somebody else is doing it.
Yeah, like one,
That's true, yeah.
like 126.
Happens all the time too, where you don't put somebody in the group.
I know, it was one of the
It's not so
conversations
little.
between the.
Just, well,
People that require number of
yeah, you
personnel
know,
on.
I've been in situations that they go in and around.
Try to do that.
I'm tired, I'm leaving at 10.
Yeah, have a lot of groundbreaking information.
Two more.
Two more for morning.
I'm already halfway through the second one, and my heart rate's still 72.
Well, you got, drink one and then you have a burrito kind of reach back here, so you.
That's what happens, yeah.
You're doing great, don't worry. Seriously. Seriously. I am not, I'm not a study driver that way. I'm seriously think, well, no, I know, but I was like, I've been, you know, trying to get through school, and I realize now as an adult learner that there are certain things that those, certain professors put on you, and you're like, you kidding? I mean, do you think I got anything better to do than this? Yeah.
You should. I can feel it from here.
Group thing. Like, there's this, yeah, well, on the campus, they have like a thing where they have a group, you have to sit there and type, hey,
Oh,
I really like
It's not.
this idea.
I would like to hear his perspective.
That is busy work. So I try to get zero. In fact, I don't think there's any busy work here.
There's some of that I
still
keep in here. I'm like, yep, you did. Where's the one I don't like getting about phones?
Yeah.
But if you want, you can take the PowerPoint out of this one. Yeah, put it all on there. You're gonna have to click into what? Just
Latest.
it's only PHLS, so you click under PHLS and then you under, you'll have lectures.
Yeah,
Lectures or
some
PowerPoint.
other dude around the area,
There might even be your, that's T-file in there, it might help you.
What about videos?
No, don't, that's too soft. Do your lectures if you want, and then do T-files. And I think it's gonna be good. It's the last time we're gonna be using that test bank, so, it won't be a big, in fact, that was next week.
You know what I just found out?
Explosions.
You know that officer video where, it goes to see on your phone? Yeah, fake. Not fake, it's a training video.
Really?
No, it's not.
Who said that?
The officer that.
They like requested the information from the police. I was on YouTube and shit looking like half minutes.
Who did?
Was it
couple
the,
different
what's
people
his name?
It's the.
posted, and there was one guy who was like, hey,
it's
I'm the
one where
officer.
Officer is like.
That's my wife. This
That's
is
the
a
internet.
And it goes to the whole video, and at the end it's like, this is a training video, like, totally could happen though.
Or something, he gets out, he's like,
Hmm.
not bad, and it's down.
And I thought that was, I thought that's been real for years.
Yeah.
I was thought, well, yeah.
Oh, yes.
I think
It's that guy with the blown off face, they show with his tongue hanging out.
That's a
and
real
blue
one.
eyes. You know, that one, like, I was on that call. No, you
I was on that call.
Yeah.
I was there,
Yeah,
man.
yeah, like, no, you
That
weren't.
was they showed us that. There was the one, there was that one where the guy jumps off the building to try to get the water, but he hits like the cement next to it, and his head's like,
Oh,
open.
yeah.
They got that innovation in. I think that's real.
Oh, the one that falls off and then they close his face and open it up?
Yeah.
No, that's real.
Yeah,
Yeah, thank goodness that they don't have HIPAA in that country.
Yeah, no, that one.
I found on Instagram, there's a lot of countries that don't, and that's some cool shit.
Yeah, there's some crazy stuff that happens.
But they're like in the ER. Did you see? the
I've
one the other
noticed
day?
though, for a class like this, so for like new EMTs and advanced EMTs, I can get away with showing those videos and everyone's like, oh, wow. But when I get into someone, say like a Kenny that's been there, he's seen, or Chief White, yeah, those videos don't work very well for them, you know? And so, I usually show more videos, but, you know, I did notice like the one where the kid was like slaps the guy on the butt on the bike and then falls out and then hits the car, you know? That messes with a lot of my guys who've been on for a while, so I try to, the whole know your audience thing, it sucks, cause like I said, I got really new people in here, but I kinda hold back on showing, cause I have literally hundreds of videos of just slams, you know?
Have you guys done many needle decompressions?
I've done several.
Yeah, I've only done 3
I've been on one and the trauma doc chewed his ass
for doing it.
for doing it. It was multiple stab wounds and he had absent lung sounds. And the doc wanted to basically wait until vital signs started crashing.
And you know what? Here's what I have to say to that doc. All those holes in his lungs, his bottom of chest tube, so nothing I did was gonna do anything different.
Right. And that's what he said, as soon as he walked out, he said, okay, doc. But he came out, he said, I'd do it the same even if I had the same color on.
Yeah.
Okay.
Yeah,
Not
he's
gonna wait.
that guy's
Not
already
gonna
bought
wait
himself a
until
chest
he's
tube,
decompensated.
already bought him. There's nothing you can do. If there's holes in the chest and you do needle decompression, no one can say a word to you. You know? Would you agree?
Yeah, if they have absent breath sounds,
Yeah, and you did one. And
It's-
even if it's a pneumo, you know?
it's technically designed for a tension pneumo, a needle decompression. But the problem is like whoever it was that did it was saying, you wait till they're under tension, they're in really serious trouble
Right.
if you wait till they're under tension. And if you can prevent them from going into a tension pneumo,
Well, and really you won't know in the field that it's a tension until late when you start
You don't know if it's
getting
tension
tracheal
or a
deviation.
pneumo, right?
right?
So you start getting those late signs and then you're screwed.
Yeah, once they start decompensating and once their pressure gets below 90 and their heart rate's 140 and so Alex is in a meeting with, Lenny. Hey, as long as everybody's here, when we were talking about calling for a helicopter,
Yeah.
don't let me give you the wrong impression. You can, if you need a helicopter, call them. Especially if you're on an incident like it that's got an, extended extrication, or you're on a search and rescue or something, that's gonna take an extended period of time. Those are the times when actually a helicopter can help you out a lot, because that transport time will be a lot less for the patient. So, you know, even in the valley here, you get a rollover on the freeway or something, and they're extricating people, and, yeah, go ahead. Call for a helicopter. Have them sit there until you can get the patient out and let them fly.
Good, Kelly. There's a little coffee in there.
I've had too much already.
Huh?
I've had too much already.
Anytime I can give service, so.
Like, very generic,
Where you going in Montana? Do you have property up there?
my father lives up there, so he lives up, near Kalispell, or Big Fork, or Glacier,
Up by Flathead Lake.
up by Flathead Lake. That's the reason I got married, is on his property up there, on the river. Yep,
That doesn't suck.
no, it's pretty fantastic,
It's beautiful.
and this is my birthday.
Is the fishing still good this
The
time of year?
fishing is incredible.
When is your birthday?
I think next Thursday, November 1st.
You check your calendar.
Yeah.
You'll just.
Visual will remind me.
Huh?
huh?
You a Cancer this time of year?
Scorpio. Scorpio. Say it
So
again.
when you were a
Fish
kid,
this time
did
of
you
year?
think trick or treating?
Yes,
Or will
or
they take it or I-
streamers, so there's my computer home screen, we call it the slow corner, it's the Swan River.
Sorry about
We've got
that.
9 different species,
I'm sorry,
out of
Elaine,
just one
about
corner of the
some
river.
Really?
Bull trout being.
Not important enough according to Kurt.
No, Kurt and Blaine
Brook
clearly
trout,
have
bull
different
X,
priorities.
cutthroat, rainbow,
I'm not
browns,
supportive.
walleye.
I unfortunately was caught in the middle.
Yep,
Anyways, it's
Perch
just,
and.
been there, done that.
Yeah.
and lake trout in this river, and height, everything, right? So big.
Is that
streamers,
lecture- I have the
trout are spawned.
Chingamadero for it, but
And so they're super aggressive, if you.
is that lecture loaded for 7A?
Little area.
Or can it be loaded for 7A?
Bull trout are the most aggressive.
I don't know.
Okay.
Trout.
I don't think I did before.
Maybe we'll call Kurt.
So it's a landlocked Dolly
Do
Varden.
you have it on a
right?
thumb drive or something, or?
Yeah, I gave it to Kurt.
So a Dolly Varden is a sea running, trout.
Okay.
Yeah, I gave it.
Actually a
I
char,
was
but
wondering, I thought all the lectures
we
were on the
call it a
same.
trout. So Dolly Varden is a sea running.
I don't know, I don't
The
have
landlocked
access to
version
any of
of
that
the Dolly
stuff.
Varden is the bull trout.
It's not up here.
All I am is an instructor, I don't know.
How'd you know all this works?
Gorgeous fish.
Is
Bull
this
trout.
the,
Yeah, it's not in there.
You got it?
No, the internet sucks.
okay, let me call Kurt.
We'll connect, Kelly.
Connect.
I'm
It's
assuming
probably
he had a
arguing with
load,
mine.
yeah,
I'm
that's
probably
probably
doing all
heated
of this right
discussion
now,
right
so.
now. I just handed him
I
the,
got it.
Good one.
The bull trout is a char family salmonid.
I just gave
in our
it.
western North
It's probably got
America.
it in his hand.
Sorry, probably in his hand.
We'll cut the shit, right? Cut the shit, Kelly.
and I'm wondering if I can get calls in here.
Yeah, you should be able to.
I was thinking about it.
It kind of looks like a brown. No, ish.
Yeah,
It's not
ish.
Some of them.
Oh, my life just got
Buddy,
really
they're,
complicated.
I've got a bunch over there.
That's gonna be fun. And they like the streamers.
They're like streamers. See, there's a gorgeous bull right there. This is
I'm gonna
great.
send Sean. Hey, Sean,
Holy shit, picture of it.
could you run and go get Kurt
Yeah.
and tell him I
Oh, no, find me.
I think this is it right here.
That
No,
corner is being
that's for the-
overtaken by
No?
grizzly bears.
Clicker.
and,
Okay,
so
tell
this is
him
super
I
hesitant,
need,
obviously.
I gave him the thumb drive for the lecture for 7A.
Is this on your?
No, it's just
Yeah.
downstream.
And he's got it.
Corley's got the thumb drive for the lecture, Alex.
I'm gonna be giving the lecture.
She's got the
But
thumb
we're
drive
gonna
if you want to.
Oh.
down there.
Give it
It's
to me a
sketchy,
copy,
but
but there's
the
not
draw.
Oh, there you go.
gotta fish that
I
corner.
realized that was a
Fourth
little.
it.
Yeah.
That's what I was
Carry
looking
a
for.
big-
No, you're good.
It's all right down there.
I'm hopefully gonna be, this will go a little quicker than shorter.
Yeah, I'm
Or-
sure, even with all that.
Right, it's still, it's still. So my dad doesn't fish, but he's lived full-time there 5 years now, he's been up there.
There wasn't
18
much,
years we
I didn't see
had the
anything in my other
property,
two lectures about the
took
fort,
down
so
Stone
I'm
Corner
just gonna cover the fort
a couple
really
years
quick.
ago for.
Yeah.
You probably have a lot more to say about it than I do, but,
He caught his first bull.
There's 1, 2, 3, and 4.
I only, there's 4 now,
No.
huh? I know, is it like burns, basically?
Bull trail.
Kind of,
Full,
One is-
will collapse.
This guy is
Yeah.
just an old warrior.
yeah.
Hopefully we don't ever come into
Yeah,
contact with
4,
that.
4 is like
Big
the
old,
whole
yeah.
face can come off.
The white
Um,
leaves on there.
where do I put this
Okay,
in?
you're all-
This guy's just an old, hombre.
I don't know how to work the pointer, but I'm assuming left and right goes. I'll figure it out.
It's just a little sketchy around.
You don't know they're there until they're there.
Right, so I'm just always with him,
7A.
talking, you have to park up here and walk down to this slow corner. I remember when there's another fisherman there, it's my little.
So,
it's where
a
I-
clicker,
it's where I want my house, it's my.
these are your forward and backward.
Yep.
So forward is on the right, backwards on the left. This middle part is your
That's my pointer. Wow.
Yeah.
Is it coming out?
Oh, cool.
Is that where you get the
Pretty,
pipe?
pretty easy stuff.
So
Okay.
they're kind of like a stream.
So the
It's all yours.
slope is
Okay.
a mile above where it comes.
Okay.
See how they're, you guys all ready?
Okay, everybody ready?
Everyone ready for
This
the next
is
lecture?
Alex Kluger. He's gonna, I'll let him introduce himself. Some of you know him, some of you don't. But he's gonna have you for the next 4 hours.
Whoa.
So,
Awesome.
long time listener, first time caller.
Hello, Alex.
Hello, everybody. I was gonna have everyone introduce themselves, but I think I know most everyone. If I don't, you can remind me along the way. I'm sure you guys have had a lot of slides and things to read. So ultimately, my goal for you, I've got 2 lectures with you. We've got head trauma, traumatic brain injuries, contusions, concussions, etc. Some physiological issues that go along with those. And then we have spinal trauma and emergencies, pretty much neurogenic shock. They took a lot of shocks away from us and moved into neurogenic, which gives us a big, huge, large portion, very in-depth. And most of this, like we get the cranial nerves, this can go for days. We could go into all the physiology and anatomy, and that's great. I think it's really good stuff. But to be quite honest, as most of you folks know, that we don't do that in the field. Field assessment comprises of recognition. So I'm hoping at the end of this lecture that most of this goes towards your recognition and teaching other people, recognizing what's bad, what's good, and when to go and when to stay and play. So a lot of these disease processes and traumatic injuries are going to be, there's nothing you're going to do. It's going to be recognition, and you need to get to the correct facility because they need trauma surgeons. So with that, we're going to go over central nervous system trauma injuries to the brain. Annually, there's a bunch of stuff that happens to a lot of people, and it's not good, and it happens to do with head trauma. We see that a lot with motorcycle wrecks. You don't wear a helmet, you're 300% more likely to get a traumatic brain injury or a debilitating injury that takes you to a trauma surgeon. So we see this all the time, we deal with it. If you guys want me to slow down or speed up or have more discussion, you just raise your hand, let me know. But I'm going to try to tool through some of this. Basic anatomy, physiology. Not going to spend a ton of time, but you have your cranium, right? The skull. You have your different layers, dura to arachnid space to your pia mater, and then you get down to your gray and your white matter. So we know what they do. for most parts of it. Our pons, our medulla oblongata, that regulates our breathing, does some really simple things. As we go through the parietal, temporal, into the frontal lobe, we get into deep thinking, we get into the cerebrum, cerebellum, and we get into deep thought and consciousness and all that fun stuff. We could go through frontal lobotomies, and there's all sorts of portions of the brains. There's a corpus callosum that's separated for people with seizures. You might hear corpus callosum used. It separates hemispheres. We got some ventricles in there. We got a bunch of squishy things, right? And they do lots of stuff, so they're important. We go into what they do, how they work. Ultimately, when dealing with the brain, it is a very sensitive organ and requires a lot of activity and requires us to really protect it. So we're going to get into what the injuries are and how we can protect those injuries. So we have a primary injury and secondary injury, and you can kind of think of those injuries in almost, they used to be called a coup and a contra coup. So we have the initial coup, or usually it can be lateral, it can be side to side, it can be a twisting motion, it could be actually a blunt trauma, force injury to the front of the head. There's your primary injury. Secondary injury is they fall backwards, right? And then that brain, there's not much room in there, but that brain can move enough, so then we hit the back of our head. So we have two lobes that are associated, or even both temporal lobes. So we have to be really aware of what the injury is and how it's affected that brain. So again, recognition. What's going on? What was the injury? How did it happen? Was it a gunshot wound? Just because it was a gunshot wound to the chest can not cause some damage. Yeah, they fell back with a pretty good force and hit their head. So now we have an associated traumatic brain injury with this, and it hit their pons and their medulla oblongata, and so now we have breathing issues. And so we move on. With the systemic and intrinsic, they're both equally important, right? So we have a lot of injury processes that move along with those injuries. So it's really, again, really important to know and recognize what those injuries are so that we can get to the meat of the problem. We can find, again, in our ACLS and PALS, everyone's usually aware of those. So I assimilate it to finding your H's and T's. So what's really the problem? And so I'll go through maybe a couple stories in between so we break stuff up. Let's go through the perfusion of the brain, which depends on maintaining adequate cerebral blood flow. And so now we get into some more interesting things that you guys are really going to worry about this stuff. No, we're not. Is it important what you know MAP is? Does anyone know what mean arterial pressure is? So mean arterial pressure is basically the minimum amount of arterial pressure required to run and have our organs function, which usually runs about 70 millimeters per watt. So about 70, anywhere up to 100 is what we need for our organs to function. And the important ones, the heart, the brain, everything within our mediastinum. So that comes into play with this because we need to look at our cerebral perfusion pressures. And then we get into our ICP, or intracranial pressures. Intracranial pressures are running around 10 to 15. And that's important to a trauma doctor. And I mean, when we get into these, we're assuming we have intracranial pressures. What's really important to everyone in this class, and especially people out in the field when you guys get done, is recognizing when you have increased cranial pressure. That's really important because there's really not much we can do, so it's just that recognition. Intracranial pressure is the pressure exerted against the inside of the skull by the intracranial. Great. Okay, so this is real interesting to me, and I find that most people, they know again, as emergency responders, it's good to know what we're doing for the purposes of understanding the physiology and why it's important for that recognition. But there's these two folks, the Monroe and Kelly, and they have a Monroe-Kelly doctrine. It's a real simple doctrine. A lot of the flight medics and trauma surgeons, they subscribe to this, and so what it is there's basically 3 parts to the brain. There's the brain tissue, the blood, and the CSF. And we're gonna look, as emergency responders, the Monroe-Kelly doctrine really plays into fact what we do, because we're gonna see, first thing, is evacuation of CSF fluid. That's first thing. So if you see CSF, you're gonna go, oh crap, I'm on the front end of this. Because we always freak out when we see CSF, right? We see CSF a lot with meningitis, with some other disease processes, severe or really elongated high temperature disease processes. And so what do we do in the field if we see, what does everyone do most of the time if they see CSF? Anybody? Bueller?
Get amped up.
They do the halo test, right? We do the halo test. Recognition, because I was on a call with some folks and we had high temperatures. It screamed meningitis, but I was the engineer that day. You hope everyone recognized, they didn't. There was CSF coming. You'll know it's CSF. It's real oily. You get the halo test. That's why it separates. Its specific gravity is very much different than blood. So we get an understanding. Great. We see CSF. Okay, so that's number 1 with the Monroe-Kelly doctrine. If you have intracranial pressures that are pushing on the brain, you're going to see CSF. That's your sign 1. Incipient phase, fire, boom, right? CSF. So if you see that, go to the hospital real fast. You're going to protect the patient, control airway, do all this stuff, but again, it's just, okay, great. And recognize and be able to tell the physician on scene or the medics, whoever is in control, hey, I see CSF, we're going. Secondary to that is blood. So you're going to expel that CSF, and then it goes to blood. So now you see oily stuff with some red stuff. Now your pucker factor just, for me, is through the roof. I'm like, oh boy, we just maybe lost this patient. Third is herniation, and we herniate brain tissue. So when you start seeing brain tissue through orifices, and it can herniate down into the spinal column, into the base of the skull, right? We can't see that, but again, we're going to see signs and symptoms. And that's where you start seeing your blown pupils, right? We get those pressures, or we get uneven blown pupils, so we can determine which side that herniation is coming from. So recognize it, be aware, and know if you start seeing herniation, I'll be honest with you, you're probably not going to have a viable patient. So it might help you determine, and I'll tell you a cool story. So I'm on a call, and we have some EMTs, brand new EMTs, and they're pretty sharp. They have a patient with massive facial trauma. I wish I had a picture for you. The patient was beat to death with a blunt object, but they're breathing, they had a respiratory component, they're on the tail end. They came out, and patient has gray matter. So I'm like, ooh, I was airway guy, I was like, ooh, gray matter. So we're gonna move on now, right? It didn't happen, and it wasn't recognized as quickly or as thoroughly as I'd like it to be, which we sometimes have to use our big boy and big girl voices to mention that to folks. So don't be afraid, because I mentioned it 3 times, because we had another patient that was possibly viable. We had some other medics on them, so ultimately that patient was taken care of, but we wasted time on a patient with gray matter, like a lot of gray matter. And it was cool to see that issue, but if you see that stuff, I admonish you to move on. You're not gonna, they might have signs of life, their medulla might be intact, they might be showing some signs of being alive, but are we gonna help that patient? Exposed brain matter, lots of blood, CSF, explosive frontal face injury. So this would be, you have your Lafort's. This is off the chart on your Lafort's picture. She had a Lafort's 4. So her whole face was basically exploded. I was able to look into airway, assess an airway, do some stuff like that, but ultimately, you have a patient with an explosive frontal face injury, and I'll tell you another story. Dude kicked by a horse. I was a medic for about a couple years. We had a guy kicked by a horse. We call a helicopter, low glucose levels, and we're freaking out over the facial injury. We don't know, but it looks bad, and he's low on glucose. So we call a helicopter. I freaked out. We get him where he's supposed to be. They call us up. They're like, superficial frontal face injury. You know, you did all the right stuff, but yeah, you freaked out. So, you know, look for those signs and symptoms over the horrific nature of the call. So that distracting call, we want to hunt and peck and make sure we get through those distracting calls and make sure it's a TBI, because he could have had another associated injuries. Luckily he didn't. But you're going to miss the hemorrhage or the GSW because you're looking at the horrific facial injury. Yeah. So we kind of went over that with the Monroe-Kelly doctrine. As ICP increases inside the skull, is compressed, blood vessels, CSF, brain, a small amount of blood can be displaced. So we have little bits. So again, recognition is real important because there's only so much fluid that can be expelled before we start getting into that herniation of brain. Hypoventilation. So this is going to tell you the causes of cerebral vasodilation. We're going to we're fighting that map, and we're fighting, so if we get high blood pressure, okay, due to blood loss, we're going to increase blood pressures and intracranial pressures, and that's going to reduce cerebral blood flow. And different disease processes and injuries to the brain causes different types of respiratory components, and ultimately we need to recognize those issues so we don't have all this stuff happen. So the hypotension, decreasing the pressures, the cerebral perfusion pressures, the vasodilation, we get more blood flow. More blood flow creates that pressure. So some of the things we can do are, we want to be really careful with that balance. And this just tells you the circle and the tissue pressures and how those play a role with one another. And as we increase those pressures, so for instance, on a patient, you have facial trauma, you have some chest trauma, let's say it's an MBA. How you start a line, where do you want to keep these people pressure-wise systolically?
85 to 90.
90. 90 is good. 90 is a really good number, right? It stays in a part with our TCCC and multi-system traumas with a hip fracture or maybe even loss of limb and we have to place tourniquet. 90 is really good because we get those clotting factors. 90 keeps us with as best as we can in the emergency field to keep homeostasis, and that's what we're hunting after. We want to keep that patient in homeostasis because we want to give them too much fluid, because then we're increasing that intracranial pressure, right? So that map, just think about your systolic blood pressure. If you push that, creates pressures throughout because we've got a head injury, possibly a head bleed, and we're forcing that pressure into the brain, which we don't want to do. We'll get into some modality and treatments here a little bit.
Alex?
Yes.
Will you go back?
Yes.
What is MAP?
So MAP is your mean arterial pressure
There
that
we
we
go,
talked
thank
about.
you. Yep,
That's
yep.
that.
Sorry, I had a brain fart.
No worries. So do you want me to define that again real quick?
Yeah.
Okay. So let me go over the average pressure in the arteries during one cardiac cycle. And it's the minimum pressure to perfuse vital organs.
Okay.
Roughly, in a male adult, you're looking about 70 to 90.
Okay.
Anything under that or over that is considered abnormal. We'll let the trauma physicians deal with that one. You're not going to measure it. Okay? You're not going to really, you're going to take, and what's really important in these patients is that trending. You're going to trend instead of every 5 to 10 minutes, you're going to trend every 3 minutes. Set your monitors up on your automatic cuff. You're going to be doing so much. Time's going to get by you really fast because these patients are real loud. You're real busy. You're doing lots of stuff. So just be advised, the tendency is trauma patient fluids, right? So be careful with your fluid administration, as we mentioned. and we wanna watch this whole cycle. So we don't wanna have too much ischemia, but yet we wanna fight that brain edema. So the more pressure and edema and that intracranial pressures that we have on these patients, we're causing that ischemia. We're tamponading vessels, and we're killing tissue. Okay? And someone told me a long time ago that brain tissue is pretty important. Okay.
Thanks.
No worries. So cerebral cortex and reticular activating systems, altered level of consciousness, the hypothalamus, you get the vomiting component, your brainstem, your effort to maintain cerebral blood flow against increasing intracranial pressures, bradycardia from vagal stimulation and increased blood pressure. So again, those pressures, it's cranial nerve 10. So people bear down or we get pressure on those cranial nerves, and we get into bradycardias. Now we're getting into dysrhythmias, and now it's a deep, horrific cycle, isn't it? Okay? And it's real important we get them to the right place. Respirations. So watch for the irregular respirations. And I don't think there's generally, with head injuries, depends on where they're at in the brain. If it's a basilar skull fracture, or maybe you have a subdural hematoma. So where it's at also determines the respiratory component with that. So just be advised, you want to look for abnormal breathing and LOC. So LOC is one of the first things you're going to look for. And we'll get in again, we're going to keep going on with the different injury processes. But brainstem, cranial nerve 3, oculomotor. So it's cranial nerve 3 is your eyeball and eyelid movement. We're going to get into some of the cranial nerves, and you've seen them do the tracking, right? So we track. So when I have a concussion or contusion, I'll take time to track. On a patient who's unconscious, I'm not going to open the eyelid and look for abnormal disconjugate gaze or conjugate gaze. Then you start moving into strokes and lesions, and you could go down a wormhole and spend it there for days. The patient needs to get somewhere to be treated. Okay. We know posturing. So there's painful stimuli, some posturing with that. There's decorticate and decerebit. I'm sure it's been pounded in my head, what's worse than the other? What's worse than the other? Decerebit posturing, right? Exterior posturing outwards, palms down. Decorticate, I think we have a little bit more time to deal with the patient. And then your seizures and herniation of the brain. Okay. Here we go. Determining the mechanism of injury and the need to consider possibility of spinal injury. So we're going to go through our ABCs. Really simple. Boom. Neurologic assessment. We're not going to really focus on a severe unconscious patient with mental status, right? Move on, right? They're unconscious. We're going to try to give that patient a Glasgow and determine whether we can control their airway with a simple adjunct or ET tube, right? Your cranial nerves. We'll go over that. Your motor functions, your sensory functions. So something I think is really important though is your pulse motor sensory, right? And that takes a second. It doesn't take long for a pulse motor sensory in a conscious patient. Unconscious patient, you can do Babinski, and you can do some reflexology at the very end, but consider really it's at the very end. So we can see if those cranial nerves or some issues are intact with doing usually a metal object that's not going to cut them. And you rub it along the sole of their foot, and they'll have that, it's the reflexology. So if you guys have a chance, Rob's got his shoes off, you can take something that's not going to cut them, but you just go from sole to top of towards the toes, and you can see that foot bend. So that's good stuff. We want to see that.
You want to touch my feet, Madison?
You know what? Again, unconscious patient, we know they have a depressed skull fracture. Not going to worry about it, right? It's the tail end of my assessment. If I got time, probably don't. And generally the first 4 are the ones considered in the pre-hospital setting. AVPU, generally regulated assessment for an infant, right? You'll see your AVPUs on your newborns and infants. Glasgow Coma Score. Glasgow Coma Score is pretty good to have a good idea. It's nice to walk through it. We're so used to doing 14s because we have verbal response is inappropriate, you know, so I can go through, but some of these you get into deeper parts of your AVPU. Don't be afraid to have an app or have something to give you exact numbers. I've had, in my younger career, I've definitely gone to the hospital and said 8 or 9 something, and we get to the hospital and they're like, okay, why 8 or 9? What exactly is their Glasgow? And I'm like, stuff and things, and they're like, that's not good enough. So next time, please be thorough, or we'll talk to someone who's above you, and I'm like, yes ma'am, yes sir. So try to have a good knowledge of somewhere to get the information. You're not going to have, a lot of this stuff, phones are really cool. So have a nice little app, look it up.
Tablet as you tap it in.
Sure, and it tells you anymore, right? That's right. It's right on the PCR. To me, sometimes that PCR goes, someone told me over the right shoulder. I don't know, I'm right-handed, so I think the right shoulder. So my phone's always with me. I can make my phone calls. I've got a lot of stuff on my phone for really things I have time to look up. But personally, I don't expect people to have Glasgow Coma Score memorized to the T. Most of us know generally what the numbers are, but we want to know generally also for the Glasgow Coma Score, because what's our number to innovate? 8. So 9 and above, we got a little bit. We can do some more assessment or repositioning, right? Where 9 is also the point where I'm like, okay, now I got to consider and get my ET tube out, and I got to get my tools out to innovate. Is that going to determine is my Glasgow Coma Score going to determine whether I innovate the patient or not? To the side it will, not generally, no. It's going to be presentation, disease process, what's going on with the patient. Do they have a compromised airway? That is what determines whether I innovate someone or not, for the most part. So here we go. Cool. Assessing for symmetry of function. Okay, that's also important. Asymmetry is abnormal until proven otherwise. In some people, asymmetry is a normal or baseline finding, so ask them. You will see some people that are response in your career, if you haven't already. People have weird eyeballs, and they have some genetic issues and whatever. One's bigger than the other. There's discoloration. Sam Garfield. There's a few other people. They're weird anyways, but I think it's all the caffeine and smoking. It's my personal opinion. Cranial nerves. All right, 12 cranial nerves. Not all cranial nerves are evaluated in the pre-hospital setting. Most important are cranial nerves responsible for evaluating eye dysfunction. So we got 2, 3, 4, and 6. So 2, optic nerve, visual info from retina to brain. Okay. You writing this down? I hope not.
Something so they can't see.
You're going to have visual disturbances. Okay, so it's the basic process. I'm showing you an apple. Do you see an apple? No, I see a stem. I see the side of the apple. I don't see. So you're going to have some visual issues. Okay, so then we go to oculomotor, which is cranial nerve 3, which is the eyeball and eyelid movement. So that's actual. So not just determining what I'm seeing, but the function of the eye.
Is that the one that dilates when the blood passes down?
I think it is.
When you have herniation.
Yes. So, but ultimately, it's your movement, right?
Okay.
And your eyelid movement. Then you have your trochlear, which is your 4. Innervates the superior oblique muscle of the eye.
Twitching? Oh. I don't know what
Sure.
that means.
Sure. It's more eye movement, and then you get into tracking, right?
Okay.
And so it tracks to the right, but I don't track to the left. Okay. The abducens. And so the abducens checks for double vision, and it affects the lateral rectus muscle. So you have anywhere from, so pupillary dilation, you have everywhere from actually seeing what you're showing me, and then you have your movement. So if you have an idea that one of those are affected, ultimately you're gonna track with the patient. If they have a disconjugate glare, they could be, they have a conjugate or disconjugate glare, they could be, it gets more into your strokes, or it actually can be looking at or looking away from the injury of where it is in the brain, so then you're going to get into symmetry of movement with their extremities on pulse motor sensory and all that fun stuff. Let's move on. Normally equal round, and so we have this anisocoria, unequal pupils, which again is normal for some people. And it suggests CNS disease of traumatic injury. So we have a difference of greater than 1 millimeter, and I also read that 0.04 to 1 millimeter is the range of differential that we want to start worrying. And we have 5 to 10% of the populace. This is normal for them. We know what makes the eyes go bigger and smaller as far as photosensitivity. So light, right, does things to the pupils, and dark does things to the pupils, right? So we constrict with light for light regulation, and we dilate with darkness, so we can see stuff and everything and whatnot. So there's also medications and there's drugs that we need to be aware of. So what are some drugs that affect pupil response?
Xanax.
Okay. What's one that we always deal with a lot?
Opioids.
Opioids. Okay, so what do opioids do to the pupil? Okay, great. What do stimulants do to the pupils? Diet. Okay. So really quickly, have you ever been on a head trauma with someone with opioids? Yeah, I've been on a few of those. I mean, so you're going to be on a call where it's not cut and dry, right? You're going to have a patient that has a TBI that might have a respiratory component, or they're diabetic and they fell downstairs. So always find the main issue, fix that issue, and move on, because we're not just dealing. Generally, doesn't seem like you go on something and it's just exactly what it got called in at. They have, they've got a cardiac problem. Okay, you get there, yeah. Now they have CHF along with the dysrhythmia. So what are you going to fix the dysrhythmia, the CHF? They're having difficulty breathing. They're feeding edema. So just go hunt peck. Make sure you follow your unconscious protocol, and we find out what the problem is so that we can get them to the right facility and take care of the problem. Extraocular movement. Assess the full range of motion. The inability to move one or both eyes indicates a neurologic deficit. Paralysis of lateral gaze, another sign of rising intracranial pressure in traumatic brain injuries. Paralysis of upward gaze may indicate an orbital floor fracture and an EOM muscle entrapment. Yeah.
What's EOM?
So extraocular movement.
Okay.
So if you have a patient too, and just to denote, I think we all know this, but if you have a single ocular injury, you just deal with that one eye. And you cover both eyes, right? Because they move simultaneously, they move in conjunction with one another. And if they don't move in conjunction with one another, so you're assessing someone, say baseball to the face, and you assess with tracking ocular movement, and you've got one eye independent of the other eye. You pretty worried now? Or you're like, okay, we're cool. Pretty worried now, because that indicates traumatic brain injury. So you have something more imposing on that patient than just an exterior intrinsic injury, right? Okay. Test your upper extremity. So here goes back to your pulse motor sensory. It's going to be a lot of similar modalities like a stroke, right? We're going to check for grip strength. We're going to check for symmetry. In the meantime, we're looking for ocular activity. We're checking for speech patterns, trying to figure out what the mechanism of injury is. Test the lower extremities, wiggle toes, push up and down their feet. You can do the Babinski. For a patient who's conscious, sensation can be evaluated by testing light, touch, perception in both upper and lower extremities. For a patient who is unconscious, the sensation can be evaluated with deep pain response. Okay. I haven't done a nail bed compression in a very, very, very long time. Sternal rubs usually give you a pretty good idea. We had a patient the other day, with possible TBI. We brought in unconscious, we got him all set up, and the doc first thing goes in and pops him right on the head. So I thought that was interesting. I don't know that I'd recommend that. I like sternal rubs, but family members probably aren't too keen to head pops. Different than a desk pop, but anyways. Reflex response
Good
for best and worst. Purposeful withdrawal from pain, cool. Non-purposeful movement to pain, flexion, extension, and then no response. Alright, mechanism of injuries. Closed head injuries, open, blunt, penetrating. Should we get into this? I don't think so. We know a lot about these. Baseball bat versus knife, right? Okay. Primary brain injuries include your skull fractures, concussions, brain contusions. So what's the difference between a contusion, concussion? Okay, so a contusion is generally very specific. So, what's your name?
Madison.
Madison. So Madison was in a bar fight, not that you go to bars.
Never.
Madison was in a bar fight and someone punched her in the side of her head. Okay, and she's got injury, it hurts there, you don't feel good, you see swelling to that point of injury, right? So we can generally say that's probably a contusion. It's very specific to a specific part of the face, the head that's being affected. Can it affect and get into other things? Sure, it can. A concussion generally is something that's a generalized head injury. So it's not, it can be generalized, it started here, but then it went generalized. So it's the general injury to the brain. Captain Aldridge?
Sure.
You have a question?
No.
Okay, no worries. Generally speaking, intracranial hemorrhage, so you have your epidural, subdural, subarachnoid, intracranial. So those depend on, we have arteries, veins involved, we have specific areas those are in, cerebral laceration, and a DAI, diffuse axonal injury. So we're going to get into these. Yeah, suggests injuries to the brain and spine, increases suspicion. So all those can cause problems and stuff. Here we get into the types. So linear, a depressed, an open closed, and basilar skull fracture. And this is your depressed skull fracture. They're bad. So again, recognition, you got to get through the blood and the mess, and you got to start looking for their signs and symptoms. Generally, what are the first signs and symptoms that are associated with a head injury?
LOC.
LOC. So LOC is your first thing because you get stolen. I've seen a few of these missed until people actually go and do a head and toe, right? They miss, they see blood, there's a lot of stuff going on, they have a lack to one side, maybe the opposing side, because remember the coup contra coup, they get hit with a baseball bat, boom, there's your depressed skull fracture, then they hit the ground and they've got a big, and what do head trauma do? What does head trauma do a lot? Bleeds, 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 bleeds. So don't be afraid to get in there and clean and find out where the injury is. You can have various stages of lucidity and LOC. It seems okay, maybe not great, and then they can crash and come back. So just really recognize also those secondary signs and symptoms with pupillary response. Get a quick baseline from family members, because what's another thing associated with head injuries and falls and people maybe in certain low socioeconomic areas? They do other things that causes that brain injury. So they're drinking. Had one just the other day, fell off a balcony onto his head, 9-foot fall, boop, right on his head. He'd been drinking quite heavily prior and maybe some other stuff. So we had pupillary response that mimicked opioid use. We had ETOH. Patient had a traumatic brain injury. There wasn't a ton of blood and a ton of swelling. So let's put you in that situation where you get that patient. So you know they had a fall. So a long fall is what?
20 feet for an adult.
20 feet for an adult generally, but generally the way I assess a long fall to me, and from my old school training, which obviously is all redefined, is taller than the patient. So if you're 6 foot and you fall 12 feet, that's a long fall. You fall 7 feet, to me that's a long fall, especially if you look at the mechanism. If they fall on their bum, protect themselves, you get there, right? You can do some assessment. They didn't hit their head as witness, it was on grass, cool, right? But I had a 9-foot fall to his head unprotected, witnessed by 5 people. It was dirt, wasn't much grass. I'm considering that, in my opinion, a long fall because of the mechanism involved. Does it really change a ton? No. The patient has potential. The mechanism's there for severe injury. So we get all these other things, and then the patient's LOC was unconscious for at least 5 minutes. No seizure activity. But right now, pupillary response is sluggish but constricted. So we found out patients, probably got some opioids on board. But there's no initial swelling, and we're doing okay. So what do you guys think of that patient? What are your thoughts? Anything, I don't care. What are you guys thinking? What's everyone thinking?
Treat worst case, you just be ETOH, but use the provider, you don't know that, so treat worst case.
Treat worst case, exactly. So we're okay, right? We're ahead of the game, and why are we ahead of the game right now?
Just do that LOC.
So respiratory drive's intact within normal ranges. Blood pressure was starting to creep. He was he was between 20 and 30, more close to 20. Healthy, muscular young man. His pressures were 140. So unconscious. So we're starting to creep. That's given me a little indication of maybe some intracranial pressure. Some pressures are starting to build. So we got him to the hospital pretty fast because I'm really worried about swelling, and I'm doing vital signs, and his pressure started to creep up slowly but surely. Because why? He has a traumatic brain injury, and he's getting increased blood pressure, which is increasing intracranial pressures, right? And so we're on the good end of things, but it could get bad really fast. I don't know what he's working on. So we went 1039, and we got him to the hospital, maintained airway, provided oxygenation. Okay, so just start to recognize your patients on the good end of things, but things can go bad really fast. And watch your pressures. Be alert and oriented to when you need to intubate the patient or secure an airway. And so that's also, I think we might get into that, but so cranial nerve 10, and you get into your innervation of your vasovagus nerve, right? What can we do if we intubate? We get really aggressive and intubate those patients right away without sedating them or oxygenating them, positioning them to see if our airway gets better. We can cause them to have they have a propensity to go Brady on us anyways because of those pressures, and then we intubate them, and we do it because we do things fast and loud generally, right? And we can Brady them down even further. So we got to be really careful with that too. Literature says don't necessarily deny airway management, but just be careful. Watch your pressures. Get capnography on them right away. Take your time. Be methodic. If you haven't taken the advanced airway class, please take it. Learn some stuff. Okay. Some of these things last, for weeks. It's not a simple fix to go to the hospital, and what they're going to do with some of these patients. Does anyone know what they do sometimes? I didn't know for a long time when we bring a trauma patient with a head injury, what do? They watch them. So concussions, contusions, right? So we have a helmeted 16-year-old kid that was playing football. He goes unconscious. You guys are at a football game. You call the medics. You get him transported. So he's definitely concussed. Okay, are they going to just run him right into a CT? Probably not. Probably not a healthy 16-year-old male with a short unconscious period, and now he's normotensive. Signs and symptoms, everything's pretty good. So they're going to go through your cranial nerve responses. Things are okay, so they're going to give you a 12 to 24-hour observation period because a lot of those times it self-reparates, right? Those contusions and concussions they fix themselves. The problem with those is long-term, right? If we know, or we've been injured, or we have children or friends that have been injured, the chances of you re-injuring and getting concussed again go through the roof after your initial concussion and or concussions. So that's a lifetime thing you gotta deal with. So now we get someone with a basilar skull fracture and you see CSF and blood and you're getting into herniation. What happens to that patient?
CT and surgery.
So they get a CT for sure. They get surgery. So what they'll do is they'll take the part of the cranium, the part of the brain that's infected, they'll take the cranium off. They'll do a craniostomy and relieve that pressure. They could actually do a burr hole if they know more specifics and they get some really good information from that CT. If it's a big, huge fracture, they'll take the cranium off and they'll let that herniation sink down, let the pressure sink down, cross their fingers and go into surgery and see what they can do. It's pretty mean. If you haven't seen a craniostomy, those are cool. I'm sure you can YouTube it. I have.
No thanks.
Okay. So now we're getting into the signs and symptoms. Loss of consciousness, amnesia, repetitive questions or statements, confusion, disorientation, headache, vomiting. I start to worry about patients with amnesia, repetitive speech, and vomiting. Those seem to be, I don't know, a lot of the head injuries that I've seen. You know, people, oh my goodness, they just get that repetitive speech, and I start to worry, and then I start to really worry about pupillary response tracking, and I've got my blood pressure on, and so also we want to think about not necessarily laying them completely supine, because where does blood go, right? So you want to worry about swelling. You don't want to sit them straight up, right? But you want to have them ramped up, so you can take your stretchers and ramp them up so their head is above their heart, and that's going to help with some of the swelling. Okay, bruising of the brain tissue, signs and symptoms include altered mental status. A lot of these are the same, right? Specific clinical findings depend on the area of the brain injured. Okay, now we're getting into the epidural, subdural, intracerebral injuries. And we're seeing this epidural hematoma, which involves the arteries. These are associated with the temporal skull fracture. Fracture damage the middle meningeal artery, lying just underneath the fracture sites. Blood collects in the epidural space between the skull and the dura mater, which causes increased ICP. Okay, cool. That's not good. Okay, signs and symptoms. Classic presentation, loss of consciousness followed by return of consciousness, lucid interval. Lucid intervals in reality not common. Deterioration of consciousness. All the stuff we talked about earlier. Paralysis on the side of the body opposite of the injury. And then seizures. So if your patient's in seizure, you can treat the seizure? Yes, please. Okay, so when we get into those seizures, we're going to see increased pressures through the roof. Is that good for the patient? No, because then we move from, if we follow that Monroe-Kelly doctrine, then we realize we're now moving into the herniation of the brain, and boy, that really gets us into some more problems than even a physician can deal with. So treat your seizures. Usually results from tearing of veins from the subdural between dura mater and arachnoid. Blood accumulates more slowly than an epidural hematoma, often associated with direct brain trauma. I had a really good friend group in high school, and one of their really good friends before I met them, he had a car accident, associated headaches, no real signs and symptoms. 2 days later, he's dead in bed, subdural. So slow head bleed from motor vehicle collision. So if you guys have any inkling, right, we don't want to release these patients. Have I seen these patients released before? I'm sure I have. Let's be honest. I try to, for me, if there's the mechanism is there, especially in patients, you want to look for patients with these head traumas and subdural bleeds. it seems weird, but you're gonna look for people with weak vascularity, like, think about your diabetic patients with neuropathies and really weak vasculatures, right? They can have, I've been on a lot of head bleeds on these patients from simple falls. Cancer patients with chemotherapy. So just think out of the box a little bit, and if ever in question, get them to the hospital. Signs and symptoms may not develop from the subdural hematoma for hours, days, or weeks following the injury. Signs and symptoms include deterioration of consciousness, dilated pupil on the side of injury, which is different than the epidural, which is the opposite side, right? So epidural is what? What vascularity does it affect? Arteries, right? Okay, subdural, that veins. And then this is opposite, not on the same side. And again, same thing, seizures. The most common post-traumatic intracranial bleed. Signs and symptoms also include headache, nausea, vomiting, may increase ICP, vasospasms, impaired cerebral circulation. Cerebral laceration, tearing of the brain tissue. You lacerate a portion of the brain. Massive destruction of brain tissue, bleeding into intracranial cavity, which results in increased cranial pressure. Symptoms vary depending on location of the laceration, size of associated intracranial hemorrhage. Really bad. So this is going to be a big injury, right? There's going to be a big mechanism here. So widespread damage. So diffuse axonal injury is a widespread damage to nerve axons. Represents a shearing injury to the nerve cells. Symptoms include diffuse cerebral edema, loss of consciousness, increased cranial pressure. As many as 90% of patients with DAIs remain in persistent comas. Okay, cool. Penetrating head injuries, gunshots, stab wounds, blunt force trauma, usually a major injury from direct damage to brain tissue. So fast and loud, those are going to be pretty easy because we can see it. We generally know what the mechanism is. There's not hunting. There's a gun there. The patient we had the other day, I totally thought was shot with a 45. It was a crowbar, and it looked like someone just went to their head, and there was the back of the head. It was crazy. It looked like there was an exit wound. So you might not know what you think you know, but there's not much really to change our modality and our treatment. And I admonish you again, if you get on one of those scenes, not always, never say never, never say always, there's secondary patients, and you might have to write a patient off. So don't be afraid of triage either. You see some patients hanging on to life, okay, the medulla oblongata is intact, they're breathing, they've got a pulse, but there's brain tissue everywhere. Don't be afraid to move on, okay? Secondary brain injuries include hypertension, hypoxia, cerebral edema, increased intracranial pressure, intracranial infections, seizures again, and it can further exacerbate the primary brain injury from these secondary injuries. Single episode of hypoxia or hypotension can make a patient's outcome much worse. By preventing these secondary problems or recognizing and correcting them if they have already occurred, a pre-hospital provider can significantly improve a patient's outcome. So we're going to do supportive care, oxygenation, patient placement. We're going to relieve that pressure as best we can. We're going to provide for 90 systolic. You're going to consider intubation. You're going to look at that oral airway. Also, if there's blood in the oral pharynx, what do you do with that? Suction. Be careful, right? Because we don't want to do fast and loud and vasovagal that patient, right? So we're going to suction. Think about maybe even using a French, but we're going to suction those patients, try to relieve that pressure and let homeostasis the best we can. If they go into seizure, hopefully you have a line placed. So get your lines in board, Don't be afraid to get that line in there. And don't be afraid to stop the seizure, because if we essentially calm the patient down physiologically, we stop seizures with Versed, patient's vomiting, so you consider maybe some Prometh. That's going to help, because the more we grunt, cough and have that intrathoracic pressures increase our intracranial pressure, and we're fighting to keep that intracranial pressure down and at its mean, consistent with our mean arterial pressures. So we have, because ultimately that circle showed us is the cycle of life for that patient is to keep everything at homeostasis. And that's what we're fighting for, because if we increase intracranial pressures, right, that puts more pressure and pushes out fluids and herniates. But if we don't have enough pressure, then we don't have enough blood flow to perfuse the brain. So it is a very delicate cycle, and that's what that little circle was trying to show you earlier. Most serious TBI presents in similar fashion. Okay, traumatic brain injuries, various reasons, processes, is very difficult, if not impossible, to determine what specific brain injury the patient has sustained in the pre-hospital setting. We generally know. Yeah, they were rock climbing and fell 20 feet. Okay, cool. We got into a bar fight, and he got hit in the head with that pool cue. Oh, it's exploded on his head. It's really not much of it left. Okay, great. We pretty much know what's going on. Early detection of increasing ICP is critical before herniation has occurred. Assess and reassess level of consciousness and how it has changed over time. So we're getting back into trending, right? So we want to make sure we trend. So just because we took pupils initially and they seemed okay, are we going to take pupils in 4 to 5 minutes? I am. I'm going to trend the living hell out of that patient. Decreasing LOC is the earliest and best indicator of increasing intracranial pressures. And then we have our evaluation methods, traumatic head injury, intracranial hypertension, warning signs of possible increased ICP, and impending herniation. So a lot of these are very similar. So Glasgow score of 2 points in declination, development of sluggish or non-reactive pupils, development of hemiplegia, hemipresis, Cushing's phenomenon. What's Cushing's phenomenon? We all know Cushing's, right?
Hypertension.
Hypertension's one.
Bradycardia and abnormal breathing.
Perfect. What's your name?
Kelly.
Kelly, you win the gold star for this. If I had one, I'd give you
Yeah.
5. Okay, so great. Are we going to see Cushing's triad right up front? No, it's a latent sign. So if you come upon a patient and you see Cushing's triad, where are you at with this patient?
Behind.
Really behind. So what might you do if you're behind on a patient and 5 o'clock and you're in Kearns?
Call the helicopter.
Call a helicopter. Thank you. Don't be afraid to call the helicopters, okay? So they have this really cool thing called mannitol. And these aren't, they're right up front. Mannitol does some good stuff. It's a big sugar molecule and it helps with that intracranial pressure, okay? We don't have that stuff. You know, they could also RSI the patient if needs be. We can RSI patients. So with these patients, we have a lot of, what I've noticed with brain injuries is abnormal. That's ultimately what happens is this patient is, they are far from normal as possible. So you would think someone with a traumatic brain injury might have a relaxed airway and they have esophageal spasming, or because they got hit in the throat on top of, you know, they got a piece of glass in their face from hitting the windshield. You don't know. So if you think you might be able to control the airway, again, everything is getting ahead of the game with these. If you see herniation, you see the CSF, you see any of that stuff, you're behind. You see Cushing's triad, or you won't see raccoon eyes for a few days. But you see Cushing's triad, that's way down the line. You're in a bad place. Get the right appropriate units to that call. And a helicopter would seem really appropriate in some certain situations. We went through Cushing, so your bradycardias, hypertension, ventilatory patterns that are different and abnormal, your different posturings. We know that. And again, we're getting back to the overall goals to prevent or recognize and treat secondary injuries. Controlling the airway, controlling your hemorrhages, recognizing your intracranial pressures, trending your patients, etc. The primary injury in most cases can be diagnosed and managed only at the receiving hospital. Super important. They need a trauma surgeon, they need a neurologist, they need stuff that we're not. Your ABCD approach, spinal motion restriction, initial resuscitation, transport and destination decisions, protecting their C-spine, long spine, securing the patients, having suction ready, being ready. So just be ready. You know what? Whenever I get one of these patients, I get my stuff ready. It's out. I'm going to be available to them if they need it. Jaw thrust maneuvers, suction, Glasgow coma score, where are you at? Monitor the patient's oxygenation, end-tidal CO2 if you get an advanced airway, and then confirm your airway tube placement. If your capnography's on, you'll know pretty quick where you're at. What's our numbers for capnography? Okay, where are we at bid-wise? If we're 10 or above, we're good, right? You're gonna watch, and it's important, trending. So we get 10, we're doing CPR, or hopefully not. We get up to into our 20s. I'm stoked. I have a patient that has abnormal breathing due to a terrific TBI, and I'm in the 20s. Right? I just won the game. Studies have shown that pre-hospital intubation and RSI have been associated with worse patient outcomes. Maybe. Why do you think that's a possibility?
Spend longer.
I think the big part is we're taking too long with these patients in the field. So we're taking time to intubate them, we're taking time to manage that airway. We can Brady them down, causing even further damage. So transport, recognition, you're out of there. It's been associated with these things and stuff. Provide oxygen, simple, easy. A single episode of hypoxia, O2 saturation of greater than 90%. Can worsen in patients with TBIs. Assist ventilations as needed. Maintain ETCO2, so your end-tidal CO2s at 35. We talked about that. Ventilation rates. We know our basic ventilation rates. You don't want to get above high end of normal. So we get into trying to overcorrect things, and that inhibits the body's ability for homeostasis, right? So we just want to try to keep the body relaxed. We want to keep the swelling down. We want to keep the patient calm. We can do that with some pharmacology, and we can do that with positioning, and we can do that with oxygenation. Hyperventilation indicated for bilateral dilated and unresponsive pupils, unequal pupils with altered LOC, abnormal posturing, neurologic deterioration. So I'm just going to tell you, be careful with your hyperventilation. The field and the literature, they're not hyperventilating anymore. It's high end of normal. If they have to do it, they're doing high end of normal, okay? We talked about our numbers, where we want to go for breaths per minute, and then our pediatric patients and children, excuse me. We've determined children, so if you get a patient who's bigger than the Broslow tape, because it seems to me whenever I've been on a kid, it seems anymore a male child at 16 to 17, they seem to be bigger than me lately. So you don't necessarily have to follow those children guidelines. Look at the kilograms. Most medicine is based on weight-based procedural pharmacological administration. So don't be afraid. You get a big kid, consider maybe even taking them to an adult trauma center. So what I usually do, we had last year, end of season, this kid reminded me of Connor DeVoe, and he was 16. I'm like, you're big. And he had a traumatic brain injury, and I called primaries because the clinic wanted us to take him to primaries. I called primaries, and I'm like, listen, the patient's adult size. He's at least 200 pounds, and he's 6'3". So they're like, yeah, you can take him to a different facility. How about a Trauma 1 center that's a little closer to you? And I'm like, that's what we were thinking, so great. I try to follow the guidelines, but I get on the phone right away and try to take them to the most appropriate facility. And by the time you get to the hospital and they're mad about hearing a 16-year-old coming, they're like, oh, okay, yeah, he's big. Controlled hyperventilation benefits: decreased blood CO2 levels, constriction of blood vessels in the brain, decreased cerebral blood volume, and decreased intracranial pressure. but we're still trying to make sure we allow for, right, the cerebral perfusion pressures and blood flow to be adequate, controlled hyperventilation, also the risks. So again, that decreased blood CO2 levels, constriction of blood vessels in the brain, decreased cerebral blood flow, and decreased oxygen delivery, increased edema. So we get back into that fine line and that real delicate flower of having to balance what's best for the patient. So we want to do, if we're going to do anything, it's going to be high to normal or homeostasis. Controlled hemorrhage and prevent anemia. Maintain adequate blood pressures and perfusions. We talked about our pressures, where they need to be, and how we're going to do that. Additional options for intracranial hypertension, treatment of seizure, sedation, chemical paralysis, osmotherapy, and that's where you get into the mannitol, which we don't have. And here's an algorithm for how you deal with that. If you want that, I'm sure Kurt can get that for you.
Yeah, we're not gonna use their algorithms, because we're gonna go into our own, algorithms for District 2Bs or state policies.
Cool.
It's nice to have it there, so I'll do that.
What's the downside of mannitol?
Mannitol does initial ICP regulation, and then it does another couple things in about 2 to 3 hours.
Yeah.
It releases pretty quick, and it's just temporary.
Seizures as well, that's why they won't give it to us, because it possibly causes seizures too, if it's pushed too quickly or whatever. So, that's another reason why they won't give us, so the anti-benzo,
Is it romazepam?
yeah, Romazcon, they
Con.
won't use that, yeah, because
Yeah.
if it's pushed incorrectly, it'll put them into seizure. So that's why they give it to the nurse and
Well, and it's
the
kind
magical
of,
red patches in the air.
it's like an RSI. I mean, we're so close to hospitals. I mean, there's a lot of stuff that we still use. Like, you go to California and they're using 30% of the medications we're using. We do really have a good amount of pharmacology in our scope of practice. So I'll try to get through this. I don't think we have much more, and we'll take a break. Component of primary assessment: visualization of all body areas and identification of hidden injuries, remove clothing as appropriate, mechanisms of injury, kinematics, and patient complaints of suspected criminal activity. Yeah, preserve evidence, maintain patient privacy, prevent body heat loss, identify the mechanism. We already talked about a lot of this. Perform primary assessment, the neurogenic shock, be advised on those. Right, number one shock that we deal with is hemorrhagic. So secondary would be the neurogenic. Which one's more important? What are you going to find? Just treat the patient. Don't ever miss. When you start shortcutting your assessments, then you miss stuff. So just be really thorough, head to toe. I really strongly advise secondary on your trauma patients. A lot of us are in 3-person crews right now. It's really hard to get all that stuff done, but get it done. Sign of TBIs is decreased mental status is the most important sign. Determine if initial findings are changing and in which direction, better or worse. Again, that trending of how you need for spinal immobilization, probably. You're going to need it. Treatment key: minimize secondary injury of the brain, correct, prevent hypoxemia, correct, prevent hypertension, avoid hyperventilation. But they said earlier some ways to correct these, like pupillary response, okay, it's ICP, high into normal, transport to an appropriate facility, okay? Questions, comments, concerns? How long, they get a good break for that one, don't they?
Yeah.
Captain Bird?
About a 3-minute break.
Okay.
You send the link for that. Yeah, of course. I can make sure I can. If you're doing
Whoa, there you go.
nice things.
We'll talk a little bit about the LaForts too when you guys get back.
See each other one.
I'm
it's upstairs, it only decreases intracranial pressure for a while, and then it gets into cerebral spinal fluid, and increases it.
For what now?
What, mannitol? That's some weird, I was just reading a little bit about
Okay.
that, it's weird stuff, man.
I don't really know, I know it's a big, huge glucose,
I was just having
molecule.
thoughts.
And I thought it was just a help with intracranial pressure.
It does, for,
Okay.
Intracranial pressure,
Yeah,
similar effects of 3% saline.
yes, and, yeah, so
But
you
then
do the
over-
3% saline
But then
too.
eventually it gets into CFS, or cerebral spinal fluid, and increases.
Okay, and I think
So
it's
kind of
about
parabolic,
2 to 3
parabolic
hours,
thing, and
you
then
start to
swings
worry about
back.
that swing, yeah.
Pretty wild. I have to be on the big issue, right?
Well,
That's somebody else's problem.
that's somebody else's problem, but I think by then, there's also some other pharmacology to help with that as well. And surgery, I mean,
That's all.
if you go, I looked up about 20 different algorithms, and at every algorithm, the end stage was trauma surgery.
Right. Right. Thanks, Alan.
Dr. Burge, where would coffee be upstairs in general?
We made coffee.
It's gone.
We'll make more coffee.
The chiefs are having meetings.
We'll
I didn't
make-
want to steal their coffee.
It's not their coffee.
Oh, okay.
It's my coffee.
It is yours?
Yeah.
Can I pay you for it?
No, absolutely not. If you want more, we will make you more.
I'm gonna go that way and then make some more.
Is it just in the break room right there?
Yes, sir.
Did you do your certification podcast thing? Mike,
What?
did you do your EMT certification podcast?
The most recent one?
Yeah.
Yeah.
What, did they give you the link there within the podcast?
Yeah,
Why don't they just put the damn link on the thing?
it just, on the, LMS, right?
Yeah.
Right?
Mm-hmm.
No. Well,
What's her name?
And Milton Berger.
yeah,
All that. That one not working. That's another day.
well, I could have it funny.
Yeah. All that. Well, I think it's, 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 I think it's,
well, the thing is, they don't know what to do, they've changed it, as of last Friday, they changed it.
So this whole podcast should have just said, we don't know how to do it yet, stand by.
I think they're just gonna tell you that they're gonna bring everyone in and pay them 4 hours to walk through the whole process. So I guess you could've done that, yes, there, I just gave you the
12 minutes of talking, just to say, you don't have to do it on your own, we'll tell you when to come in,
Right.
stand by.
That's why I'm your
Holy
friend
shit,
today.
man.
There you go.
Jesus Christ, thanks Kurt.
Yeah,
That's
you're gonna come
great.
in, they're gonna make you do it.
I got podcast fatigue. One more 360, and one more podcast, and I'm gonna freak out.
Oh, no, I agree with you saying. In fact, for me, I have this little, rebelliousness that every time I send a 360, I just delete it. I don't even look.
We're finding it.
Well, here's the thing, the chief. The chief used the 360 to fire people. Now he uses them to fuck people, and I don't like it. I hate it.
I don't know if that's accurate.
Just, it gives people opportunities to troll about stuff that is dumb. And I guess the thing is, I'll take one on me, that's fine, go ahead.
So I gotta put it in context. I don't know if we want to put the leadership stuff that they're doing right now, is the work training.
I would do it for that, cause I've been asked to do it for that, but for someone's job promotion, I'm not touching it. Cause I think it is, I mean, and I'll probably
You don't get
give
the
it.
bitch, you get what you get.
Yeah.
I hope it was said.
Cause I don't think it's a fair, well, how about this? I
Quit saying that word, man. You gotta quit using that fucking word.
Okay, it's not fair, how about this? You're right, it's not about fair, I just don't think it's an accurate account for what that person is.
It's not supposed to be an accurate account, it's not supposed to.
I agree.
It's supposed to be,
I agree.
someone's perception of that person more than not.
Yeah.
Which is pretty important, pretty telling.
I guess. So go ahead and give one on me, but I just don't want to participate in that.
How many?
Okay.
I'm sorry, not to.
I think Quinn had a good time. Came on an RTF. But I'll only do one if I directly work
It's all
with
right.
that person.
He's trying to get rid of
Coffin. Oh, I think he likes
Like,
it.
I read one the other day, they nailed the guy for not, several years ago, not paying for dinner in the station.
This is.
And again, I'm like,
So he's a
okay,
crook.
was that true or not, I don't know, but okay.
But who cares?
Well,
It's
we
weird.
should have paid, but maybe we're not, you know?
Exactly.
Yeah.
Some of them, right?
Anyway.
You can read through that though.
Well, I hope it's read through, but the thing is, it's still a record about you, and, you know, go ahead, make a record about me, but I don't wanna participate, make it a record about you.
Hey, what's the EMT reg site, is it the EMS board registry stuff?
Yeah.
And then, does that have our NAEMT number on it?
Yeah, we probably do.
There's some place I
I-
registered with NAEMT like 6 months ago.
Yeah, so you have to go to the national registry for that one, and you have to go to the state for that one, and
Is that this one?
Misha has, yes.
Whoa, I did, now I don't know.
Why are you so tired? Because you have two of these bad boys.
Monsters. I need my NAEMT number. Is that?
Oh,
Can I get
you know
that?
what, something to discuss too.
What's that? Under my
Is
credentials?
redoing
Possibly,
our.
not Mish as well, I can get it for you.
They're heading, right, 1, 2, 3, 4, 5.
Oh, just editing it.
5,
Bingo.
19 or 20, they're
My regular number.
So I was
You're right,
sitting back
Kenny,
there
it's
one
not
night,
fair. It's just,
sniffing
I just,
that's
it gives
down
me
to
heartburn.
here, at Gaines,
And then,
and where are my numbers?
Oh, if you're gonna say I'm
It
right,
would
don't
even
say
them out
fair.
more, right, it would be like 11,
yeah, life's not fair.
oh, yep, 11, 13, and 14,
Okay.
so,
Good, even up the time a little bit on it.
right there, there's the better one. That would be the actual chapter breakdown, it would just be more even.
Okay.
Right, rather than 5, 20. So someone brought that up to me, I thought it was good. Yeah, where, yeah, 'cause It's in the binder. So we'll look at it, we'll pass that out to them tonight.
Make some copies for them.
Oh, yeah, those guys, Mike, are gonna take a beating in LA, just like the guys in Vegas, or in Clark County did. 7 years ago, 8 years ago.
What did they do down there? What was their resolution?
What was the, county's resolution?
Clark County or?
Disband the heavy rescue, that team, they were serious.
I think I'm working at 109 this week.
Utilizing
Are ya?
Mm-hmm.
Dude, we should all be so lucky.
On a constant, huh?
Oh, no, of my,
Disband.
my regular shift day.
They said we no longer have them.
So, yeah.
Yeah.
Wow.
We no longer have heavy rescue happening.
Should we go next door and get
It
together?
was?
Yeah.
Oh, yeah.
There's a meeting right next door to ours.
I was
You
gonna
guys
go
go
there,
there,
you
right?
can- I guess
And they
the
will
wheels
Figure out
are
the
kind of
I'll find a better way.
Yeah.
I'm moving on one
Come with me.
to staff these programs. He said we won't do it.
Where were you
We said,
wanting to go?
Copy that. Okay, to get you out of that environment. They took out
Yeah.
the
Okay,
county,
cool.
took off billboards, took out front page ads, and
grabbed all my shit.
listing.
But yeah, hopefully I'm there for a while. Watch 109.
Hey,
Hey.
cause the union started doing slants that are on.
Oh, that's great people too.
I
worked there for friends.
Yeah, saying they're trying to.
December.
That's a lot of fun.
Yeah.
You got Ryan and Mark always bitching at each other.
And they were, oh, we're not playing this one.
I'm telling you right now, companies gotta watch out for fucking fireworks, then taping
It was bad.
the sink,
The
so
guys
it
in
sprays you when you turn it
Oh,
on.
man.
They do it all the time.
Could not have been more pleased.
Captain
Owen Henderson.
Sandberg has a fucking kick band.
Yeah.
He will like, if he is boot scooting boogieing a little bit to get in like 2 o'clock in
We
the
were down
morning
there
into the
teaching
building,
SAT class.
it's cause he's putting on the
After
kick
he
band.
starts to quit, the task force as well. We disbanded the heavy
He's, I'll hide around the urinal wall. A lot of
He
times,
said-
his favorite place is Ryan's room.
Oh, real good nuggets.
Yeah.
Yeah, no,
It's
he's,
an issue.
it's key, he never scared me.
Right. The way they're structured down there, they pay everything time and a half. for each
Do it.
thing.
I don't like pigs.
And the grant just pays for that stuff.
Limbs
Which
last
is why they don't have any money on that leftover in the grant funds. All their money goes to
That's fun.
time and a half training for the task force members.
Good.
And,
Yeah, I think that'll work out.
They call
What's
it-
What's that?
All the children say, instructors, they call the English. Hired me,
Not that I know of.
saying more instructors.
I think last night I
One
think.
guy that's willing to
Just
participate.
let,
He was a U.S.
yeah, they're like,
Where's here?
I wanna use the letter. So you write it, and then you come down with a hammer, like, I don't wanna do that. But,
Oh, that's awesome, that's cool.
Yeah, we grant,
We don't want it to be the souls.
right. I don't wanna get my fingerprints on that train wreck.
That would be fun to go to their house or, you know, that'd be really cool.
it's cool to have a chief as your.
But yeah.
I've only taken the prison, I've only taken the ride twice, but I know not to.
Yeah, it's hard.
Oh, that's not yeah.
All right. Giddy up.
Yeah.
Yeah.
But I tell you what, I love her about working with Raleigh, you know, I mean, she does everything that, so like, Archie upstairs makes these big decisions, right? But she is, everything on the bottom line of, she's finance, she's payroll, she's quality assurance, yeah, she is, staffing.
Bugging waves.
He's just the guy from, I mean, he's just the guy from the agency.
They know when they're doing.
Whether he wants to.
Snipping classes is like.
That's hundred and making extra grand.
I like some of those, I'm so sorry.
Okay. They did, so Park City's doing all of this,
Park City's
except for,
doing all of it.
except for SCT.
Oh, I think this is our year too.
What's that?
Our youth are putting all on.
Are you doing?
I'll do some of them at least.
Cool.
I'll do rows because I suck at it.
Cool.
I
that roast was supposed to be in the spring, but it might be in the fall now, just because I think it sounded like SCT was moved back or something.
No, yeah, I used to want to do, were you doing, how much has that stuff? You just went to the monitor class.
Yeah, I just went to the monitor class. That's all I've done.
They got, they're supposed to have another training program that goes over like, USAR specific, cash,
Oh, really? Yeah, it was more like a curious thing for me, it's not my focus right now. It's interesting to me, but, right.
Hey, Kurt, how do I get this to expand?
Go to file, up on top of say,
Just say Siri, enhance.
no, go back,
Slide.
go to slide, show, yeah.
Uh-oh.
Up top, Klug.
On the very top line,
Bottom right.
start
Down
from
lower.
all the way to the left.
To the left, now back to the right, and then down lower.
Yes, yes.
Oh my gosh.
Lower, right there, yeah.
I need some more participation though, really, Rob, if this is gonna.
We just got to bust through this.
Okay, if you want to do that?
We just gotta get through it.
Okay, let's just get through it. Let's look at your Lafort's paper really quick. So, John told me there's now a Lafort's, there's a Lafort's
No.
4, which is a full, so just be advised, you can imagine what you're dealing with anatomically, right? With a Lafort's 1 versus 3 versus a 2. It's pretty straightforward. Do you guys need to be able to diagnose a Lafort's fracture?
No.
Probably not. Massive facial trauma with excessive bleeding. Your Lafort's 1. I've seen all of them, and I can't, after I get to 2, I go, bad stuff happened to that person's face, and we're gonna go, right? So, yeah, just so you have, you know how to define it, but I don't know if you're gonna be tested on that. There you go. And it's, the way I've been taught on Lafort's, again, we can get into it, but it's really neither here nor there, is ultimately it's like a car. Our body has breaking points within our anatomy, so if we get hit, so that it protects our brain. Ultimately, the Lafort's, just if you ever are in a testing situation, generally it's going to ask you, like, you know, why is the body set up for Lafort's fractures, define this fracture, whatever. Ultimately, it's breaking patterns and relief positions in our anatomy to protect our brain. Okay, so the next is going to be central nervous system trauma and spinal injuries. Lots of stuff. Lots of spinal injuries occur annually. And weird, young people, right? Spinal injuries, same with traumatic brain injuries. A lot of spinal injuries are going to occur in lots of younger men. Weird.
Good job.
Yep, good job. Causes include motor vehicle collisions. Sorry, we're going away from MVAs. So just remember that too, terminology-wise. We're going to motor vehicle collisions, because it's a purpose, not an accident. And then we're going to submersion injuries instead of drowning. So if you hear that, the whole medical folks and the people and the stuff, we're transitioning. Falls, penetrating injuries, sports injuries, other improper assessment and management can result in permanent paralysis. So that's a big thing, part of this too. Recognition, recognition, recognition. There's your vertebrae. Does anyone not know that grandma went to the desert and broke her coccyx? We all know that story.
I don't know
No?
that story.
Napoleon Dynamite? Oh my gosh.
Oh, yeah.
Yeah. Eat your dinner, Tina? Come on. Okay, so yeah. And so, just for WTFs, so we're looking at what, C5 is the big bony process right here by our neck. So if you get that or below, it's a problem. You get a cervical spine injury, right? We're worried. So below that process, generally we see decent outcomes, not great outcomes. Above that, so if you get pain, step off anything above that bony process high on the cervical C-spine, you're gonna freak the F out. Now inside, not on the outside. Outside you're gonna be cool like clams, right? But on the inside, you really wanna start looking for abnormal breathing patterns, we wanna start looking for real big red flags, elephants in the room by the dozen when you see fractures above that. So be super high cognizant of those patients with high cervical injuries, because we could see patients with not only irregular respiratory drives, but agonal breathing. Basically, they're not gonna be breathing for very long, so be advised. Here's the anatomy on the spiny process, looking straight down. Yep, the anatomy's right over there. We can look at this when you guys have time, if you wanna look at it and get online and do all that kind of stuff. Spinal cord fills the spinal canal, leaves little room for swelling and hemorrhage or bone injury. So you can have like your herniated discs, you can have bone on bone. Obviously we go from injury to herniation to actually bone on bone. And then hopefully proposition 2, I'll keep my mouth shut, contains motor and sensory tracts, the tracts from nerves that go to specific areas of the body, sensory or motor, right? More anatomy and how those nerves fall through our spinal cord, going up and down, pain and temperature sensation, opposite side, position and vibration sensation. So really complicated stuff actually when you get into it and we get into the dermatomes. Sensory levels, spinal cord nerves exit each vertebral level and detect sensation in specific areas of the body. Sure, okay. And then we get into our dermatomes and we can see through each spinal column upon our cervical down through our coccyx actually translates into feeling, sensation, temperature regulation, and feeling and touch throughout our body. Pretty cool stuff.
Yeah.
So get a chance, look at your dermatomes, and it's cool what the F. So sorry, excuse me. Primary injury, damage that occurs at the moment of impact. Secondary injury that occurs subsequent to the initial impact. So your systemic versus your intrinsic. Pre-hospital management can often prevent or minimize the effects of secondary injury. So we got to make sure we protect C-spines, get them on the spinal board, long board, your KEDs if you need. So don't be afraid. Systemic causes, hypoxia, hypotension, anemia, or blood loss, increased or decreased CO2 levels. A lot of the same stuff, again, we're going to see that mimics head injuries. So another real important reason why we do head to toes. Determine the mechanism of injury and the need to consider possible spine injuries, airway compromise. What's that? Anybody? Okay, ventilatory compromise, adequate oxygenation, adequate circulation, perfusion. Neurologic assessment for disability, so your mental status, cranial nerves, motor function, sensory function, coordination, reflexes. Dermatomes are really important, so don't be afraid to do your pulse motor sensory. Okay, distal extremity assessments, so we know, great, where we're looking at and where we can suspect that spinal issue or fracture. Your AFPU alert, all that fun stuff, pulse, whatever, provides initial impression, mostly for pediatrics, your Glasgow Coma score, and then your numerical values for those, which we went over earlier. Assessing for symmetry of function, movement and sensation is key. We get into the asymmetry. Is this normal baseline for you? Test upper extremities by having the patient, again, same, it's all very repetitive. It's the last slideshow we looked at. For a patient who's conscious with a suspected spinal injury, assess dermatomes to estimate the level of spine injury, start at the head, down to toe, level of loss of sensation. So then we're going to get into the actual dermatomes, what we're looking at as far as the sensation. Are you guys really super worried? Are you going to go through this every jot and tittle? No. You're going to look for the injury. You're going to recognize the injury. Are there signs and symptoms? How's my distal postmotor sensory? How's my level of consciousness? And then you're going to go. In an unconscious patient, assess for sensation with deep pain response. Your reflexology. Okay, down on the list of what we're going to do on scene. Trauma to the spine result in a fracture, your spinal cord injury. So I would be a little bit more alert on, do I have a complete fracture, which includes a step off, what the mechanism is, you know, what the injury just basically is in a nutshell real quickly. Okay. Here's your spinal injury in the cord, outside of the cord, and their definitions, if you're interested. Your motor response, muscle weakness, complete paralysis, sensory pain, your numbness. Young men have a certain process we joke about a lot, but ultimately we see male appendages and they're doing abnormal things, suspect severe spinal injury, right? High cervical injuries, cervical collars break at very low fracture points, 5 pounds. That's why cops go for them with their sticks, right? Batons. It's an easy fracture, puts people down pretty quick. Look for associated other spinal injuries with those. Pretty common. Paralysis of diaphragm and intercostal muscles results in total loss of ability to breathe. So again, those high cervical fractures. I was watching a stupid video my kids were showing me with Cosgriff, what's her name? She was on iCarly. Yeah.
I don't have kids.
Okay, there's a popular kids girl, and she dresses up like Michael Jackson, and she does all these dances and whatnot, and it's pretty popular amongst the tweens and whatnot. And so this guy comes up to show off to her, some guy out of the street, and he does a backflip, and he lands on his head, and he dies. So just, you know, simple injuries.
Like this was an episode, or this really happened?
It really happened.
This was an episode?
Right?
The children.
She was dancing in front of a large audience, mostly kids, and this guy comes up on a chair, does a backflip, lands on his neck, and he's done. And she's still dancing. But, you know, and guess who he was? He was a male between the ages of 16 and 34.
Good for him. Good job.
Weird, huh? Okay.
Good job.
I digress. So lower cervical injuries, diaphragm still functions, paralysis of intercostal muscles. So we want to look for anything we have with high cervical, low cervical. We're going to be worried about airway, but again, that's one thing you should be assessing. LOC and airway, really important, because they're going to be at the point where they're physiologically unable to maintain and manage their airway. Cervical or high thoracic spinal cord injuries may result in hypertension. Disruption of sympathetic nervous system results in unopposed parasympathetic tone, vasodilation, bradycardia, warm, dry skins, right? They're flush. You can be on that snowboarder, lots of head injuries, not wearing a helmet, high cervical spine, they do okay, they hit that plateau, and then their airway drops. So be prepared to support airway. However, the most likely, which must be ruled out before calling it neuroshock. Overall goal is to prevent, recognize, and treat secondary spinal cord injuries, all that stuff. Pre-hospital setting, assessments, and approach, we know that. Maintain spinal motion restriction as appropriate for the mechanisms of the injury. Jaw thrust to protect the spine. Clear the airway, so if you see blood, bone issues, we're going to make sure that airway is maintained with slight elevation and suction. Maintain it, Glasgow, we went through the Glasgow. If active airway management is required, monitor. So we're going to start with oxygenation. We're going to make sure we trend for blood pressures and tidal CO2 if we place. You can also put your nasal cannula capnography on them, right? That's an option for us. Confirm proper tube placement. Oxygenation. What's generally the magic number? We went over a magic number for end-tidal CO2. What's the magic number for oxygenation right now?
95. 94 to 98.
93%.
93.
See it on a test, it's probably going to be 93% or above, you're good. You're happy. You're in your happy place.
Couple slides back.
To help them out, it's gonna be probably, so not to contradict them on this one, but.
Sorry, you
It's
can.
gonna be somewhere between 96, don't always put 100%. So between 94 and 96, just try to shoot for that.
Thank you.
Yeah, because that's their new magic number.
I think it was just a couple slides back says 95.
Thank you. Again, it's not gonna be hyperventilation, it's gonna be high normal. So we're trying to allow the body for homeostasis, so it can correct its own issues with our supportive care. Adult respiratory rates, boom. Usually 1 every 6 seconds on adults. Control hemorrhage and prevent anemia. Again, we are talking about those numbers, 90 to 100, generally 90 on your systolic blood pressures. A single episode of hypertension and BP, so you're looking at less than 90, worsens outcome in patients with central nervous system injuries. You're not going to use this algorithm, you're going to use Kirk's algorithm. Look for the mechanism of injury. Do your head to toe. Don't be afraid to do your secondary, etc. Someone has a fall, look for that TBI. If they fall on their feet, looking for lower extremity crush injuries into lower spinal column, coccyx, etc. Look for that mechanism. Distracting injuries, we all know distracting injuries. Now the problem is do we know how to overcome a distracting injury? Hopefully you do. If not, try to. And generally what I do to overcome distracting injuries is I do a head to toe, and then I start focusing on my big injuries, and I say, hey, if you see something bleeding, deal with it. If it needs a tourniquet, deal with it. If it's open, if it's anything below their chest, cool. You know, if it's I had a femoral tear, and so I was airway person. So it was nice because I was working with Ben Edgeworth, super awesome, amazing medic, and should be, yeah, the guy is freaking awesome, way better than me. Anyway, so I was focused on airway, and all I did was focus on airway. I made sure to open the airway was patent, look for secretions, look for head trauma, and all that sort of stuff. Got a tourniquet on in no time, and so I went from, hey, we're clear on airway, what else do we got? I didn't even really know what was going on lower because we had someone that was dealing with that. So it's nice to delegate that as a patient person to go, great, I'm going to be looking for big life-threatening stuff. You look for little life-threatening stuff, and we'll meet in the middle. So it usually works with me, and my assessments go well. Long bone fractures, suspected visceral injuries, large lacerations, degloving, those are pretty distracting. Large burns, any other injury that produces acute functional impairment. Inability to communicate. Okay, and some of these are going to be just because the patient can't communicate anyways. I think that's the point of this. So they're hearing or speech impaired, they speak a foreign language, which is really funny, but we get a lot of patients up at the resorts and they don't speak a lick of English. And so you got to try to get through it. And again, a lot of non-verbal responses and Google Translate. Small children. So what are we going to do to help communicate with small children?
Mom and dad.
Mom and dad. Thank you, sir. Unstable spinal fractures from penetrating trauma are extremely rare. Okay. Life-threatening conditions take priority. Prevent secondary injuries. And then steroids for spinal cord injury no longer recommended. I think that's a little bit more advanced medicine than we're used to. Transport destination. So make sure you take care of the secondary injuries. If they're out snowmobiling, they're on skis, we're going to start seeing this cross-country injuries, and they've got a possible spinal cord injury. Find that spinal cord injury, recognize it, but also take care of them. They're hypothermic, secondary TBIs, long bone fractures. So just treat that patient generally. Component of primary assessment allows visualization of all body areas and identification of hidden injuries. Now this is a big one to me, and I've been talking about this with a lot of people in the fire industry. I am not a huge fan of anything under the underwear. I'm just not. So some people might be, you might see it. In my opinion, if you can tell me why, cool. I've been on no patients that required me to take off underwear. Now, it's different if you're doing an arrest and you need to take off a female's top to do CPR. Totally appropriate, right? But anything under than that, in my person, let's be respectful and let's be mindful of not only the patient but family members, because you're going to make the family members really not happy about that either, and especially people coming in on a busy scene with a big traumatic injury on a patient. So if you need to, do it. But I'm really having a hard time with a lot of dudes just stripping people down to nothing. Okay? So that's just my little soapbox, and we'll move on. We go back to the criminal history, preserve evidence, et cetera, patient privacy. I'm huge on patient privacy. Put a sheet up. We just spec'd out some ambulances. Hopefully we all like those with the door forward for privacy of the patient. Give that patient some privacy. Do what you got to do. We'll leave that up to the officers. I think our officers really do a good job, so we need to be better, I think, listening to them. So we need to communicate. Big communicate.
Yeah.
Prevent the body loss and heat.
Listen up.
Identify the mechanisms of injury. Great, we know all this. Key determination and final. Initial findings are changing. So we're getting down into the neurogenic shock. So we're going to look for the respiratory component, pupillary response, LOC, and get them to the right place, right time. It's been going out of popularity. I'm a big, let's protect C-spine. Okay, I'm okay with making my patient okay. I put a headbed on, I put my back raft on. So just always make sure I always make sure I've got 2 or 3 back rafts before shift. It's just me. I like to have them. It doesn't make our patient completely perfect, like they're not totally comfortable, especially coming down out of the ski resorts. Be mindful. But you know what? Perfect example, we get a kid. It was the same kid we took to a different place from one of the clinics. And we go in, he has got repetitive speech, he's nauseated, the nurse gave him oral Zofran and is starting a line. So I'm like, can we put C-spine on the patient? Let's give him some oxygen because it's a head injury, and we're gonna go real fast. And she's like, nope, we did images. We're refusing C-spine because you're gonna make them uncomfortable going down on a longboard to the valley for at least a 30-minute transport, blah, 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 blah. So I'm like, okay, you sure? 3 times I ask. 3 times I'm denied. And this isn't necessary, it's just, we all miss stuff, right? We're all not perfect. I miss stuff, that's why you guys are doing what you're doing, so you can catch us and we can be better practitioners. We get down, we call primaries, because I'm not taking him to primaries, he's huge. And they're like, oh, so he had 2 lower reported lumbar fractures that were imaged at the clinic. So do you have them on C-spine precautions? Do you have backboard? Do you have a back raft? And we're like, no, but we're gonna pull over and do those things because we were refused 3 times by the clinic for those procedures from a physician. So I'm just gonna tell you a recommendation is if you think you need it, the hospital's probably not gonna freak out if you overtreat on a patient with a suspected TBI and spinal injury. I recommend you do it, and this is how I recommend it. Once you're done with that clinic, even though you get refused several times, you pull over to the side of the road and you do those things, because it's best for our patient. So don't be afraid just because a doctor tells you to do something because they've got 30 patients and they're busy. Most of the time, the doctors are going to give you good information, but they're people and they make mistakes. So if your gut tells you to protect the C-spine, please protect the C-spine. That's it.
No.
Questions, comments, concerns? All right.
No, sir.
Alright, Coralie's gonna send out, an email, right? Already done, so we'll send that. There's a study guide on there, and, PowerPoint,
For this?
okay? The study guide looks like, post-test, but it really is a study guide.
Copy.
That gives you an opportunity to kind of see what kind of damage will happen on Tuesday when you take your written test.
Copy.
Okay?
Is it gonna be an assignment again?
You'll be on LMS.
Do you want me to pull
Thank you.
that Bob for you? I'll get it. Don't worry about it.
Oh, okay, I'm sorry.
Right.
Okay, any other questions, heartburns, anything you guys need?
I think so.
I tried to register this with the ADM, so I know I've done that.
Let's
Oh, you
move
got-
off
you
upstairs.
tried to do it?
Get
Well,
that info.
Did you do your
Get
national anthem?
you out of here.
all
Okay.
sorts of fun
So,
stuff then.
So you're not gonna have to do national unless
Thank
you,
you for teaching.
well, you're gonna have to do national for the AMT and then you'll be a national AMT.
Thanks for the advice.
What else you doing today,
I've
Trent?
absorbed it.
Yeah.
I'm,
Yeah.
oh,
That's one
fine,
of the-
don't talk to me.
In fact,
Very
right,
access.
in
Yeah,
fact,
you too.
you don't have to be
Thanks for
involved
putting
in
up with me.
something.
No problem. Have a good day.
Every year.
That's it, really.
Yeah, for 4 years.
I know, you know,
It's good to have that training.
there's no reason for anybody in this class to sit down with Misha and maybe do something.
Work on
Yeah.
Register
a
as
fog
national
for
AMT.
multifamily
We're not
homes.
finishing. Oh, hey.
So that's it.
That's true.
You got all the.
So that's all.
Yeah, because you're gonna get completely re-up and
And I got
reset.
this.
Complete reset. Alright.
Bye, everybody.
Have a good one.
Have a good day. Just like that, we're out again? Man, you guys are awesome.
Okay, we're done. Shutting off. Oh, nobody's there anyway.